has been done in the last few years. They have seen the costing, the cost incurred to the staff, salaries, heads, including doctors, staff, paramedicals, technicians. 50 to 60% of the cost is on this segment, followed by the labs and the other imaging part and the treatment down the line. So, and in a corporate sector, we have a little space to lay off the staffs. Rather, we need more hands to deal with the over every day the demands are increasing, the patient's loads is increasing. So on that cost cutting era, the states government should think of how to channelize the patients to different centers so that the ratio of doctors and the patient get properly managed. Coming to the treatment portions and the moment we receive the patient in our emergency department, we need to have the basic investigation plus the advanced imaging, including CT, MRI, because whatever when we are working at tertiary care center, we have to most of the cases referred from the other primary centers, district care hospitals, and the big and the small nursing homes. So already case has been work up there, and we have to now pinpoint the diagnosis so that we can manage properly and give the better clinical outcomes. So we can't afford cost cutting at this level, this point of care, in the imaging or in a what you say in the lab parameters. We have to do the test. Although, what I just have a one little space we can maneuver. They are the where we can maneuver a little bit in the cost cutting era. Like there is few investigations we do in a lab which are not very much standardized, like procalcitonin level, anti-proBNP levels, vitamin B12 levels, folates levels. These are not basically we can put these tests on the lower sites of the investigations. So on these way we can little bit can somehow help our patients and the hospitals to a little bit take care of the cost cutting issues. And coming to the treatment part, once the diagnosis is pinpointed, the treatment, there is no compromise in cost cutting. Be in a government setup, we are working at tertiary care center or wherever it is. Treatment has to be the patient oriented, diagnosis oriented, and the properly instilled. And one thing we can do in a treatment protocol, we have to be having a fixed hospital policy regarding antibiotic policy, and we should adopt strictly the antibiotic steroid program in place, so that the antibiotic use, the high end use, we should focus our antibiotic use so that at the clinical diagnosis oriented. So and whatever empirical treatment if we have to start at emergency department, that will help, may help to some extent in cost cutting. So in nutshell, we have to although the margin between the cost cutting and the having the not compromising with the clinical outcome, the margin is very thin and fragile, but we should never lose any opportunity so that we can come up with the new ideas how to do the thing in a more cost effective way.
Thank you, sir, for your words of wisdom. It gives us a lot of things to ponder. One thing I must point out, that about 10 to 40% of the cost of running a hospital is for the running of emergency department. And in 2015, an apex tertiary emergency department with about 1,35,000 annual footfalls, the cost of running the department was 25 crores, 16 lakh rupees. So if it is a government sector, it is borne by the government. Otherwise, we have to think who will bear it. And the words what Sarat told, that no compromise with the quality. So I call upon Dr. Sudeepa Das, who is an expert in forensic medicine and medical legal affairs, to tell us about what will happen if this cost cutting will result in some deterioration of the condition of the patient or some untoward effects. Thank you, ma'am.
Thank you all to the dignitaries. We are here. So cost cutting, the debate on that, it's not a very easy issue, and we don't find for easy solutions, easy answers. It's a very complex, rather evolving topic for all of us to debate and deliberate. For me, and in my opinion, I can just say that cost cutting should never be at the behest of the clinical outcome of the patient. In our state, Odisha, for many BPL card holders, below poverty line holders, our Chief Minister has taken much care to provide them with the BSKY card so that at time of emergency even they can avail the best of the treatment both in the corporate sector as well as in the government sector, and also the referral points. Like I work in Barampur and I have seen the patients with complicated and complex diseases being referred to Vishakhapatnam as well. Also in Apollo, Amri, also they have some 10 to 20% patients are being referred there for treatment. So that way we have got a very kind and a very considerate Chief Minister who considers that come what may, no life should be lost. Every life is precious. But however, saying all that, we need to evolve around the strategies, to strategize, to plan, and what we should cut out, what we should not like go on spending money for conduction of tests and laboratory imaging and all, which do not have a much favorable outcome on the diagnosis. Because if we cut on costs, then we also cut on making important diagnosis or misdiagnosis. And those misdiagnoses and that also stuff, cutting costs like cutting back on the supplies, the services and the staffing pattern of any corporate hospital, no doubt will put a hold on the bed, so that in times of need, emergent need, the patients don't have enough beds to. So for me, in my opinion, we should always use evidence-based guidelines and protocols to standardize the care, the services, and reduce the unnecessary and unwanted tests and like the imaging, the CT scan, which that depends on the clinical, how the physician will diagnose it, and then it ultimately is treated. And one should, the goal that should improve the efficiency of the physician, efficiency by empowering the available staff. They should use the new technologies, the digitalization methods and procedures are in vogue today. And so that automate the tasks, and that also like it facilitates the patient care services. Using alternative payment models to reward hospitals and the corporate sector, both the government setup as well as the private setup, and reduce the wait time for the patients. As well as by carefully, we have to consider that which which are the diagnostic patterns that can be deleted, so that they can be only those that is completely essential for the treatment of the patients must be done at a first and foremost level, so that the unwanted things that should not be incorporated again and again. Suppose he has done the test in some government hospital, and again the corporate hospital will again start from from zero. You have to do all the laboratory tests like the hemoglobin and DC, TLC, whatever. That is deemed is unnecessary, unwanted, unwarranted. That may also lose most of the time and will start in the that will delay in the start of the management of the patients. So we have to carefully consider, and we have to carefully consider the consequences of how to weigh, how to carefully integrate the pros and cons of deleting certain the tests that are the age old. It has been already been done, so that we can focus only on the patient-centric services that definitely has got a bearable outcome on a good outcome of the patient. Also, we have to integrate our services in such a manner that prevention is better than cure. We all must be knowing that. And so to preventive approach, how to prevent, and the chronic diseases like the diabetes and certain orthopedic diseases which have this chronic diseases, how that can be alleviated. We have to focus on that, so that finally when they have some acute illnesses, these patients, they have some acute onset of symptoms. So that doesn't end up in poorer outcomes. At the end of the day, the patient should not be having so much of emergent situation. He must not face so much of such an emergency that he should be rushed, and the outcome definitely and naturally that goes bleaker and bleaker. Because for us as a doctor, as a physician, as a medical legal expert, as Article 21 says, every life is precious, and the physician's first and foremost goal, that is to preserve the life of the patient. And we should not say, because if we are cutting on costs, but someone else should not be paying the price, definitely the family is paying the price of losing such patient. That is mine.
Thank you, madam. Actually, when we are studying about the costs borne by the emergency department, and the cost effectiveness is always calculated with the Delhi disability limited years and how much we are getting per rupee expended for the emergency care. And it is a huge social benefit, what we can see. The question is not compromising with the quality, but to make emergency care affordable. Before I call upon Professor Shudas David, let me say a memory of him. I had attended a conference in Kolkata on stroke where he was the speaker. It was about 18 years ago, and I practiced in a place about 60 kilometers from Kolkata, and that time we had no 24/7 CT facilities over there. So I asked him, "Sir, if I have a patient of stroke at 10 p.m. in the night, so what should I do? Should I treat him here or should I send him to Kolkata?" And the answer which he gave me still rings in my mind. I want to share it with you. He just told, "Ask yourself, what should you do if the patient was your own father?" So with these words, I call upon Sir to briefly give us the insight and the balanced approach between the affordable emergency care and the quality of the care.
Thank you, Dr. Tarak. Honestly, I don't even remember speaking to you. Ladies and gentlemen, when this topic was given to us, we were wondering how we should handle it so that ultimately the beneficiaries, that is all of you, would have some take-home messages regarding cost cutting and its effect on clinical outcome. Let me just touch upon some of the points which you have heard so far. Professor Bowie talked about what happens in AIIMS. And I must say that he is really blessed to be working in an institution which is the flagship medical institution for the country, which is directly under the supervision of the top-notch administrators of the country. So therefore, they set a reference point, a benchmark, which hopefully each and every institution would try to aspire for. But he talked about what happens in the government sector. And in the government sector, a lot depends on the people at the helm of the institution. If you take, for example, a district level hospital, because I was involved with the 12th 5-year plan, the 12th 5-year plan, and we were looking at emergency medical response. I was one of the task force members for the Ministry of Health and Family Welfare. And there was this felt need across the country that we should have trauma training courses. The buzzword was trauma those days. Although I expressed very clearly that, yes, thank you for inviting me to be part of this group, but I'm not in favor of having just a trauma center, because trauma constitutes only 5 to 20%, depends where you are. That's the registrations which come into an emergency department from the causative factor of trauma. The rest is all non-trauma causes. So therefore, to have an emergency department rather than to have a trauma care center would be the prudent way to go. But of course, there are a lot of political pressures. And once again, as I reiterated, it all depends on the people at the helm of the institution. And if you take, for example, what Dr. Deepak was talking about, he spoke about the private sector. And he brought about a very good example where he talked about biomarkers and the role of biomarkers in early diagnosis and also monitoring of progress or regress of a disease behavior in a patient. But in the private sector, once again, there are two factors. Who's going to bear the cost? To begin with, all said and done, there has to be an investment. So as administrators, people want to look at what exactly would be the cost that the institution would incur and how would the institution recover the cost. I've been the medical director of a medical college hospital, so I have sat in that seat, so therefore I know what exactly happens in the private sector of medical institutions, medical teaching institutions. Always there is a cost-benefit ratio which requires to be reviewed, analyzed, and then a decision taken regarding how exactly we're going to go about. So therefore, there is a cost factor which comes into the picture. And we listened to Dr. Sudeepa, and she was talking about so many aspects, and the point which I wish to emphasize upon, I know you have to go, wish you a safe flight back home, no problem, go ahead. He's flying out shortly from Durgapur airport, so as I was saying, from Dr. Sudeepa's point of view, from the forensic point of view, we have missed out a very important point. All of us who are working in the private sector, we need to remember about the Consumer Protection Act. We come under the CPA and we are bound by it. Government institutions, public sector institutions do not come under that. So therefore, we have to make sure that in the so-called cost-cutting processes, we do not compromise on any aspect of the patient care, be it in diagnosis, be it in treatment, that it will jeopardize the safety of the medical personnel. That's a very important point. Because as private institutions, when we are reluctant to investigate, say in a point of care system, can I have a show of hands how many people do not have point of care system in your hospitals? That is, at the bedside, in the emergency department, you will be able to look for biomarkers for acute coronary syndrome, should be able to look for pulmonary embolism. Can I have a show of hands? Yes. You see, the person here on the dais does not have in the emergency department. There are many emergency departments which do not have a 12 lead ECG available. You have to keep changing the position and you get a long strip. And if you do not place your leads properly, or if the nurse who takes the ECG does not keep it properly, you're going to have a diagnostic issue. So on and so forth. Ultrasonography. How many of you have ultrasonography with you? We saw a very nice moulage where there was intra-abdominal bleeding which was picked up by a bedside ultrasonography. POCUS we call it. Point of care ultrasonography. How many institutions, how many emergency departments, can I have a show of hands, who do not have an ultrasonogram in your respective departments? See? So we, look at that. So these are all the realistic need of the hour for our institutions. And why is it not happening? It's because of cost cutting, or because the people who are the movers and the shakers of the institutions have not yet realized the need that if you want to provide quality emergency care, if you want to improve the clinical outcome, you have to invest. Do not expect to reap when you do not sow. It's as simple as that. The emergency departments have to be empowered with point of care testing, with POCUS, with a proper ECG machine, and all these things are basic essentials which have to be taken care of by the institution. How you're going to recover it is different, because in management we studies that profit is of two kinds. Profit is just not money alone. Profit is classified into tangible benefits and intangible benefits, or tangible profits and intangible profits. If today the Mission Hospital of Durgapur is very well known, and if patients are coming from all over the state, neighboring states, across the country, from international, it is because of the intangible benefit of reputation which you have built up. But you have built up the reputation for care once a patient comes into the hospital on an elective basis. What happens to the patients who come for emergency care? Have you built up your reputation? This is where managers, top-level managers, need to see what are the intangible benefits which an institution will gain if we invest in the right things to make sure that the clinical outcome is improved, not affected, but improved from where we stand. So therefore, I think without any doubts, there has to be an investment which needs to be made. How you're going to recover it is different. We heard about tenecteplase. What about simple, how many hospitals do not have a stroke protocol? Can I have a show of hands? Stroke protocol in your respective hospitals. You see, there are a couple, 3, 4 coming up. So therefore, we need to really work on these things. Wherever you may come from, please be the spokesman or spokeswoman for your respective institutions. Make sure that your management invests enough money so that you will increase and improve the quality of care that you deliver to your patients. Thank you.
Thank you, sir. We are really enlightened by this discussion. Anything, any contribution from the house?
Yes, we would really like some feedback.
Yeah.
Thank you. Excellent discussion regarding cost cutting and not to do cost cutting. Now, the problem with physician is what he should do. In emergency, you take care very good. After that, patient goes to ward or ICU. You need to do some tests which are essential. Like I'll tell one, which probably before we have discussed that a patient came with trauma and immediately shifted to OT, but we don't do any survey by the trauma team. We have forgot that you need to do a multimodal scan. What you need a CT scan to exactly localize where is the injury, whether it's spleen or liver or somewhere else. That is very easy for the surgeon to prepare himself to go for a surgery. Simultaneously, you are doing multi-point surgeries, say abdomen, then you can go for the skeletal system. So that need a multimodality screening, CT scan, because you take 5 minutes to do a CT scan of whole body. I mean, plan scan. And now we have 25, 250 slices, you can see the exact point of bleeding. I'm giving an example of a big hospital in Bangalore. I don't taking the name. I was in a workshop. They were treating a patient for falling hemoglobin for 10 days. They didn't do a CT scan. After 10 days, when they did the CT scan, they found it is a retroperitoneal bleed. So that is why, where you compromise? Where you will compromise that the treatment or the investigation part? Because ultimately you need the result. And the result bring you whether a doctor or the institution they name. So it's a very thin line to actually mark the where to do, where not to do, how much you will do, how much you will not to do. A procalcitonin may a valuable point when a patient doesn't have any kind of other investigation shows you that whether need antibiotic, don't need antibiotic, escalate antibiotic or de-escalate antibiotic. So I have a small question for Professor David, that should we go for a liberal investigation or we should go for a controlled investigation, then comes the therapy, because it's about emergency, so I'm not going to the therapy part for the antibiotic and so on. So what is your opinion regarding this free investigation or liberal investigation to pinpoint the diagnosis as quickly as possible?
Check. That was a very valid point and insight that you provided. Would you like to say something? I will add at the end once if you give your views on that, because you work in the private sector. So his question is very relevant to the
Dr.
private
Das
sector.
is my colleague, and we discuss these points on regular basis. Where do we stop investigating our patients? But I agree with Dr. Das. Whenever we are in dilemma, whenever diagnosis is not sure, the working diagnosis is demanding something more to be done, then we should not compromise in the doing more investigations. But for the sake of just complete the workup, just do this, that, do that, why not? As we have seen, even when they have the PRO-ACT trial, the procalcitonin trial, when they have taken the data, they found to be there is no significant difference between the antibiotic duration, doses, and the benefit versus the patient who are not followed through the procalcitonin algorithm and without procalcitonin algorithm. So procalcitonin and some serial biomarker test on daily basis, these tests, I think we should, as a clinician, we can't take that much risk. I will say we have to take such much risk. As a clinician, the patient party will say, Doctor Sahab, aap jo hai wo karo. But he will say, but as a driver, suppose driver is driving our car, and I will say him, driver sahab theek se chalo. But driver sahab kitna chalega, he will decide. So driver sahab has to take the responsibility how he should drive a car. Being a health professional, we have to take a responsibility to take care of the out-of-pocket expenditure also. We can't just throw our whole responsibility to we overburden our system, as we are the resources limited country. So we need all set of investigation before to give the result, or for the sake of the best clinical outcome.
Absolutely. No, I would endorse what Dr. Deepak was also saying, because as clinicians, we are quite often walking the tightrope. On one side, there is evidence-based protocols. There are protocols which are drawn up either by the US, most often by the US, which we try to emulate and follow. And I am one person who always believes in indigenization. Actually, it should be the other way around. See, they treat 50 patients, write a paper. We read that and we treat 50,000 patients. It should be, we should be writing after proper research and analysis, and they should be following, because they have the lesser number of cases. Now, people are beginning to realize that there has been an overkill, especially in trauma, where trauma centers were investigating all patients with everything, including pan scan. What you are talking about is the pan scan, where the whole body is scanned from the head all the way down below the pelvis, including the mid shaft of femur. Everything is evaluated. Because, yes, there are missed diagnoses which are picked up later. But who's the one at fault? We. We have not really assessed the patient properly. There is no substitution for clinical acumen. And I believe we Indians are the best in clinical assessment in the world. Trust me, I have worked everywhere. I have worked in the US, I have worked in the UK, I have trained and worked in Australia. There's nobody better than Indians when it comes to clinical assessment and management. We should exploit on this. We don't have to subject every patient to a pan scan. It's like throwing a net, trying to catch fish. You end up catching snakes, crabs, everything else. What we are looking for are fish. What we are investigating is for a specific purpose. We are not doing a pan scan just to make sure that something is not missed out. Incident of something getting missed out is 0.04%. Once again, in trauma management, in all other clinical conditions, not only assessment is important, reassessment is important. Who is doing that? That's the question. Is reassessment being done by the emergency department, or when the patient gets shifted either to the ICU or to the ward, is it being redone by the physician in that place? Apart from the primary survey and the secondary survey that we talk about, there is a tertiary assessment. And the tertiary assessment has to be done 24 hours later by the physician under whom the patient is admitted. How often do we as consultants go down and re-evaluate the patient? We are always busy talking to the junior, asking about investigations, and giving all kinds of excuses to ourselves when things don't look right. How many of us have the discipline of touching and evaluating every patient? That is a very important point. Whichever specialty you may belong to, we need to make sure that we reassess our patients. And if that was done, this patient, this was the textbook description of a retroperitoneal hemorrhage. Luckily, he did not have a duodenal rupture of D2, D3. But that also will not manifest at the time when a patient is presenting himself or herself after a blunt trauma of the abdomen. It will present 5 days later, 6 days later as sepsis. That's because we have not put our hands on the abdomen. So the point remains that what you have said is correct. We should not compromise. We should not compromise on what we think needs to be done. We can easily compromise and remove this factor where every patient who comes in undergoes, X-rays and CTs. That's why, there is something called as an Ottawa ankle rule. There is something called as a Canadian C-spine rule. All these were brought about. Why? Because it was shown that it is an overkill. Every patient was subjected to any number of X-rays, exposed to so much of radiation through CT scan, that it was not really required, because the outcome, it did not really matter much to the outcome at all. So they devised and gave you strictures so that you reduce the number of investigations. So as Indians, I think we need to make sure that we study all these things, get an understanding, and should not have investigations are not a substitute for proper assessment and repeated assessment.
Thank you, sir. I hope these discussions from the stalwarts were able to quench some of our doubts regarding the cost effectiveness, the affordability of care, and the cost recovery. Thank you all. Let's proceed to the next session.
I would like to request all our speakers and moderators to be on stage.
First of all, we request Dr. Tarak sir to kindly felicitate Dr. Sudeepa Das ma'am, as it could not be done before.
I would like to call Dr. Makhanal sir to felicitate all our speakers and moderators. Thank you. Moving on to our next topic, assessing quality of emergency care. India as a developing country have a long way to go to establish a standardized emergency care which will be both accessible and affordable in terms of excellence as compared to Western world. So today we have a panel discussion comprising of experts from reputed institutions to have an assessment of quality of emergency care in India, to appraise where we stand and where we need to go. So calling on stage Dr. Tirtha Mukherjee sir, HOD of Accident and Emergency Medicine from the Mission Hospital, Durgapur.
Dr. Mekhla Paul ma'am, Consultant Accident and Emergency Medicine, Mission Hospital.
Professor Dr. Makhanlal Saha from WBCRC.
Dr. Deepak Kumar sir, Consultant Nephrologist, Mission Hospital.
Dr. Shantanu Kumar Das, Director of MICU from the Mission Hospital, Durgapur.
Hello, hello. Good afternoon, everyone. So, as the day wears on, we have seen and heard from multiple stalwarts in this seminar, which has really gave us lots of food for thought and enlightened our knowledge, made us wiser, and helped us to think more humbly, more logically, and more rationally. So now we are going to talk upon a particular distressing, I would say it is a very distressing topic for all of us, which is assessing the quality of emergency care. Being in a city which is far off from the main town, Kolkata, we have had lots of problems in mitigating disasters, in treating patients who have come from a long way off, have been referred from other hospitals, have been brought in unattended, and the mission hospital had been the first point of care. So me and my colleague, Dr. Mekla, she is an MD emergency medicine and have done PDCC in critical care. So she has been working with us for the last 4 years, I think from 2019 onwards. So we have seen lots of ifs and buts and dark side of the treatment part. So we are not here to accuse or to blame or to point out, but we would rather say that there are multiple issues which needs to be looked into from the doctor's perspective. Definitely there is the perspective of the patient and the patient relatives, and there is a perspective of the administration. But from the doctor's perspective, if we think, there are lots of things which needs to be achieved, which we have heard from Dr. Bhoi that multiple states are doing very good, and we have learned from Dr. Suresh David and from Dr. Subroto Das that things are looking up in the future, things are going to get better. So here we are actually talking about what the ideal quality of an emergency department should be. So the purpose of EM is to support the flow of life. So as we all know, life, the spirit comes into the cage and then leaves the cage. So EM is standing there plumb in the middle, trying to help the flow of life. The right care to the right patient at the right time. So that is very much important. That is the motto of the emergency care. ER serves all patients based on time-bound practice frameworks and is guided by prioritization. So prioritization and in instant care, even counseling a person that what sort of treatment you need, that even falls into the part of an emergency physician. It's not always that you will be treating the patient. Sometimes it will be just that I have been there, I have been getting treated for the last 20, 30, 40 years, things have not get better. Rather it is getting worse. And they come into the emergency department to ask that what should I do, where should I go? So even counseling those sort of patients, or letting a patient go after a successful resuscitation and the patient is good enough, after 6 hours we find that the patient is okay to go. Then advising the patient, talking with the patient relative, deciding upon the course that the patient has to take while at home, that even is a part of emergency care. So, next.
Now, what is the relevance of the emergency medicine care? So, what is the difference between the emergency care and the OPD service? The main difference is the availability of doctors over the 24/7 hours in emergency care service. What types of patients usually come in our emergency? Either specialist is not available, most probably at the midnight time, or maybe the disease or the severity of the illness is so much acute or overwhelming that immediately some quick services will be needed, and it will not be manageable on OPD basis. Then patients usually come in our emergency department. So the uniqueness of the emergency is the availability of the point of care tests, continuous monitoring and reassessment, and along with the goal directed treatments can change the outcome, and it will be definitely along with our effectiveness and efficiency.
emergency, I actually, the first time I had a talk with some of my colleagues, I had jokingly said, emergency, okay, emergency. Try to come out from your shell and try to see what's happening around you. So there are lots of things which needs to be taken care of. After around 20 years of emergency care in this country, there are still lots of things to be seen. I'm not talking about a, what do you call it, A-grade town like the metropolis. I am talking about the peripheries. So there is a deficient awareness about disease. So in multiple cases we find that the parents or the patient attendants or the patient himself, they have not been able to understand what ails them, what is their main problem, where to go and at which point to arrive to the emergency department. So which is why sometimes very shockingly they have been brought to the emergency department at a time when we could not help them anymore. So that is a very important part. So public awareness is missing. Number two, there is lack of infrastructure, both in the pre-hospital and in the hospital. So what do we think about the pre-hospital sector? Roads have to be made, and there should be vehicles available. Those vehicles should be manned properly. And then the buildings, if you are thinking about a healthcare sector, the building, the machines, and the availability of the medicines, those are all very much important. Next, the lack of trained manpower. Again, the doctors and the nursing staff, they are actually the backbone of any medical setup. So recertification, retraining, getting updated, these are very important. But in India, usually these are not done. So that is another part which needs to be addressed to. People should come to a consensus as to the line of treatment that should be followed in each and every cases. Because we have had this sort of patients where we have found that the burn care, treatment of burn has not been done properly. We have seen that that patient having a myocardial infarction has been started on injection meropenem because the counts were high. So these sort of multiple problems have been exposed. So those have to be checked by proper trained manpower.
Especially one thing, especially number of cases we have seen in our emergency department that say 70 to 80% of burn patients, and the event has been already 6 hours back, and patient was being treated in outside hospital for last 2 to 3 hours, but how much fluid he or she has been received, it is not actually documented in any paper. Or in case of trauma, airway is not protected. At least by giving normal oxygen, we can prevent a secondary brain injury, but this is totally lacking in peripheral hospitals.
Right. Then the financial viability for care and the lack of integrated pre-hospital care and poor pre-hospital care. So these are all very much important and needs to be checked in. Next.
Now coming to the trends, this is the disease adjusted life years lost per 1 lakh population, and it has been according to the WHO report published in 2018 and revised in 2020, it is seen that the major problem is the burden of the non-communicable disease, which is the major cause of mortality in the emergency related deaths, and it is surpassing all the non-communicable communicable and communicable diseases and trauma, and it is irrespective of any income group, that is in all low income, middle income and high groups. In every point the major mortality is caused by the non-communicable diseases, and even in irrespective of all the regions, all the countries also, non-communicable disease is the main problem.
So who has come up with this particular data? It's a projection from 2015 to 2030, which actually shows that the number of deaths due to non-communicable diseases is on the rise. Non-communicable disease means the cardiac ailments, stroke and cancer. So these are the non-communicable diseases from which the number of deaths are high. Why we are talking about this? Because these sort of patients, if they come to our doorstep at any point of time, day or night, if not taken properly care of, the whole disease process will actually, the death will win. So there are, the helps can be put into that, milestones can be established in the patient's life, which which will make life altering scenarios. So for that, emergency care is absolutely necessary. Strong emergency care.
And these, the trends of 2015 and 2030, it is also seen. Now the maternal and child care is another area of social well-being where vigilance and readiness to respond helps to mitigate the complications and morbidity, like hemorrhage, hypertensive disease like pregnancy-induced hypertension and infection lead to life-threatening pregnancy complications. And sick children deteriorate fast during multiple illnesses and urgent emergency care is needed actually. Newborns with neonatal sepsis, meningitis and respiratory distress, they are not properly being properly cared in very much periphery hospitals or nursing homes. Children with surgical emergencies and injuries and prematurity and pneumonia are the prime cause of under 5 mortality.
So next we come to the quality in emergency care. A good emergency care setup should have a easy and free access. So it should be properly in the ground floor, and there should be free treatment, which is absolutely necessary. Then timely, efficient and patient-centered care should be instituted. Prioritization of sick patients should be done. No patient who is very sick should wait. And competent clinicians should be doing the triage. Early decision making should be done by the senior most physician. You cannot ask the juniors to first go see the patient and I will come later. So if the patient is sick, the senior most physician should come over and make the decision as soon as possible. That actually helps in the patient outcome. And less waiting time, good pain relief. Again, that is another underrated subject in hospital while around the India. Pain relief is not good, so good pain relief should be instituted. Clear communication and counseling should be done. We should always remember that emergency is a matter of a setup. It can never, you cannot sit at a shop and do emergency medicine. So this is actually a hospital protocol or a system of care where the duty of care comes at the top. So a smooth transition of care and patient satisfaction, that should be there. And proper discharge process should be there, and minimum clinical and drug related errors should be there.
Now, what are the quality indicators as per our NABH criteria? The main points I have highlighted, that average time taken for initial assessment, return within 72 hours with similar complaints, incidence of medication error like prescription error, transcription error or any dispensing error, percentage of adverse drug reactions, percentage of transfusion reactions and percentage of near miss events, incidence of patient falls and percentage of non-compliance to infection control practices. These all are monitored, and audit usually is done monthly basis in our hospital. So what are the criteria of the good emergency care system? There are multiple metrics. Those are like safety, like avoiding injuries to patients from the care that is intended to help them. Effectiveness, that is providing services based on the scientific knowledge to all who could benefit, and refraining from providing services to those not likely to benefit. It should be patient-centered, like providing care that is respectful and responsive to individual patient preferences, needs and values. Timeliness, that is reducing waits and sometimes harmful delays for both those who receive and those who give care. And efficiency, like avoiding waste, including waste of equipments, supplies, ideas and energies. And equitability, like providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location and socioeconomic status.
So ultimately, the duty of care is a combination of knowledge and funds, technology, commitment and respect, quality assurance and infrastructure. So all these things comes together to make an ideal emergency department and ideal emergency care. Thank you.
Actually, the topic was little different. What my feeling was, it was a quality assessment of emergency care. If you have a setup in your emergency different hospitals, we can measure the outcome, how best you are giving care. And we should keep in mind that if you go to the Western data, Western standard, they have their own set parameters, which we can never match. If you go to the trauma deaths in Western countries, the pre-hospital care, their hospital emergencies, the outcome is fantastic, mortality less than 5%. In our setup, our mortality is anything between 15 to 20%. So this particular aspect, how to assess your quality of care, they have mentioned all the points, but yes, my point is, you have mentioned the points, but to assess how best, I assume Mission Hospital is one of the best hospital in this area who are giving best emergency care. But one has to have objective assessment of these points. If I say some points in trauma, we have a study for 10 years. And we have in the study have found that whenever a trauma patient comes to general emergency, that emergency is crowded with stroke, with other medical emergencies and the trauma. And the average time required for the patient to get the first attention is around 15 to 20 minutes, number one. Number two, the physician who is first examining the patient is not trained in the basic trauma care. There are incidences where the physician has not put his stethoscope in the chest to find out whether there is hemothorax or pneumothorax. And these few parameters, if you study properly, you will find that the result, outcome of these patients in center A is better than outcome in center B. So that is the idea of quality assessment, where you can objectively measure that in your setup, these are the parameters you are following, and your outcome is this. The mortality, the morbidity, everything depends on the objective assessment. You cannot take, you see, if you go to the different studies, there has been a parameters of 50 to 70 parameters which has been identified to assess the quality of care. So it is difficult in all situations to apply all these parameters, but there are some parameters we can always apply. One has to do audit. If you are doing a good emergency services, at the end of month, you have to have an audit. How many patients are in emergency? And what these parameters you have followed in your practice, so that you can claim, yes, my approach to this patient was this parameter on this objective assessment, and we feel that we have achieved the quality of care.
So, I'm taking sir's view to one more point. What is quality of emergency care? Three things I believe. One is early assessment. Second is the critical interventions. Third is time gold therapy. These three. Now, we should be assessing the patient like primary survey, secondary survey for trauma patients, patients with medical emergencies like sepsis, shock, hemorrhagic shock, cardiogenic shock. First thing we should, how quickly we finish the assessment. First assessment. And if it is a patient of say MI, now need to investigate and then you do the critical interventions. So how quickly you do a ECG and a echo and a marker and you come to a diagnosis, that is called provisional diagnosis. So how quickly you come to the provisional diagnosis so that you can start treatment early. Now if you diagnose MI, then you have to give STK, tenactibage, whatever you have to give, how early you can give the thrombolytics. Now in septic shock, you have to resuscitate, take the airway, ABC, whatever normally it's a common thing in emergency. You take care of ABCs, then come to provisional diagnosis, and how quickly you give antibiotic. Like there is a goal called within less than 1 hour you have to give antibiotic, before they have to take culture. So we have to have audit on this. So how quickly we have come to resuscitate and made the possible a minimum MAP, how quickly we have given antibiotic in this patient. So these are all quality indicators. Like intubation, cross intubation is not actually, or it's a elective intubation to take a airway control. So these are all, there are parameters you can audit on, and you can say, yes, we have done this. And another thing is transfusion. What is your TOT? How quickly the blood comes from the blood bank and you can transfuse, because patient is exsanguinating like anything. So these are all things we will audit, that how quickly you can able to do.
Sir, as per our NABH guidelines, we have the quality indicators which are usually followed. It's written out there that whether the average time to initial assessment. In the mission hospital, it is less than around 1 minute or so. The moment the patient comes, we are there to see the patient, and it is usually the senior-most physician who do the triage.
No, you cannot say a particular time for all patients. The point is, at the end of month, that is what I am trying to emphasize.
Yes, sir.
That these parameters, whatever indicator you will take, suppose you have seen 200 patients.
Yes.
You cannot claim that I have seen
Average.
all patients in 5 minutes time.
Average.
You cannot claim that I have taken this MI patient to my theatre for primary angioplasty in this half an hour time. So these are the parameters, these are the indicators. The first, if you are doing a trauma patient, the standard guideline is within 30 minutes you have to do a fast. If you are doing fast after 6 hours, that means you are violating one of the parameters which is an indicator of good outcome. So what I am trying to say is, your policy is to see in 10 minutes, I agree. But what I am trying to say is, each patient have all the markers. What you have done, this. At the end of the month, you review what you have done with your 200 patients that need to hospital.
Internal audit.
Yeah.
Internal
That is the thing. That gives you the quality, because hospital mission is doing this parameter in this time and this outcome. Another hospital, same indicator, they are performing poorly. So that is how a quality assessment is done. As I said, in Western countries, the system they follow, their patient number flow is much less than us. They can have a different criteria. But our criteria, yes, we still try to improve. We are not achieving the Western standard, but if you follow these guidelines, if you follow these parameters and try to achieve, as I said, now people are saying that patient is coming to acute MI, primary angioplasty standard of care. And the time taken from arrival to the theatre is important. That affects outcome. So that is your criteria of good care.
We have, sir, we have our audit system by quality team, all including emergency, ICU and everything. We have data, the turnout time, then MI, primary angioplasty. So ultimately in the end of the year, we'll analyze those and we'll see where we are. And there are areas of improvements or not. So every hospital has got that kind of problem and it will continue to be there. So we have to improve day by day. One day the Rome is not built. So we have come across from 2008 to 2023 being one of the top hospital in the country. So we have good qualities, and in fact we have a system of assessing patient by a senior ED physician and a junior. Both of them assess. Then they first see the primary diagnosis, then they call consultant comes and see, and we go on doing the critical interventions or a therapy, whatever needed. So we have a data, probably that NABH and all, when it comes we analyze and present to them. That is there.
Sir.
I have been listening all your comments. Yes, I have got two important questions. Have you got any retrospective data of clinical auditing of emergency care in your hospital and how the curve is going up, say 5 years back and 5 years since, including morbidity, mortality, spectrum, quality of care and patient satisfaction.
Sir, every
That
6
is very
months.
important, and that is a measure of the quality care of any emergency hospital or accident and emergency unit. That is, unless we have got a data-driven presentations, I think you will not ever improve either retrospective data or prospective data. Make a prospective data and then you can show that this is my hospital, I have done this much of improvement, I could not do this, then I have improved over this period. That becomes a very objective way of presentation to mention about the quality care, which is one of the very important index of any emergency or critical care unit of any hospital.
Yeah,
Sir, our quality team of IIHMR graduates and Dr. Taraknath Tarabdar, who is the in charge of the quality team, they actually go through all the files and all the treatment summaries and everything, almost every day. Yes, sir. And
okay,
every
then
month
I ask a question.
we have those. Yes, sir.
Did your emergency cares improved with appointment
Yes,
of
sir.
a specialist in emergency medicine MD?
Yes, we have.
That is what Dr. Mukherjee is saying.
We have improved.
Yes,
We have
but
definitely
that have to be an objective parameters. The point is, the criteria we are saying that these are the parameters, and day by day you are having new gadgets.
Yes, sir.
Day by day having, because MD emergency medicine was not a specialty.
Yes.
So if a MD emergency medicine person has joined, what was happening before she joined? Maybe 4 years back, what was your outcome data? And what has happened over the years that some specialist has joined? Has the attitude has changed? Has this criteria been changed to some extent on the better side? Because you can always outcome the data. Yes, Dr. Tarak can say.
এখান থেকে না, স্যার কাছে।
Sir, actually, what you said, we have all those data, but this presentation was meant for a general concept of the quality in the all of emergencies, what we can follow, because we are trying to develop emergency care in the peripheries and all those things. So what points they should look after when they are planning for their quality. So we have all those data, but we haven't presented it here, because we go on regularly for quality assessment, quality audits, clinical audits.
We had generalized the topic.
Yeah, sir. And I would say, right now our emergency remains overcrowded. We have a space problem. We initially started with a 9-bedded emergency, and now at any average point of time, we have 17 patients. So we are really working on expanding our emergency right now, and we think within next 6-7 months we'll be able to add more beds, about 20 more beds. Regarding the quality of care and everything, we have data. I would like to add another thing, sir. No quality care can't be given if the healthcare workers themselves do not have a proper, safe lifestyle. So we have also done studies. Our clinical psychologist is there on the burnout problems in the emergency, and we had presented in Delhi the patient safety conference this year. It was alarming, sir. It was alarming. Most of our brothers, I would say rather 80% are suffering from burnout. We know it is very much stressed environment all over India, all over the world to work in an emergency. But in our hospital, we have those studies, and we are planning this mitigation and all these things.
Sir, we have, sir, point data collection. Every day we collect data from everywhere. I mean, from emergency ICU ward, and we collect it and put it all together and analyze it. Only a problem in emergency, what I feel is our emergency is overcrowded, very much overcrowded, and I think most of the emergencies in our country the crowded by the relatives, sir. Most of the relatives, they're anxious, they want to know what has happened. Now our physicians are assessing or doing some intervention, putting a tube, they have to take them out of the emergency. It's difficult sometimes because somebody is crying, somebody is also falling down in the emergency. So sometimes it's very difficult. I know the previous discussion they told my emergency bed is 10, 10. 10, is this not possible in India? Sir, is it possible? Dr. Suresh, Professor Suresh and I, Dr. Mukherjee also I'll ask, is it possible, sir, contain the emergency beds? That this is the emergency bed, we cannot intake the patient because we have rush of patient one point of time, which is difficult to handle.
There's something that I thought I will add on. First and foremost, my wish for the Mission Hospital Durgapur is that you achieve two things. One is that you will become eligible to start DNB in emergency medicine. And my second wish and prayer for you is that you will become a standalone NABH Center of Excellence. You are accredited as an institution, and I think if you work hard enough and in the right way, you should get special accreditation for your emergency department. However, there is work to be done. Like for example, your presentation today, I understand, has been for general understanding, but I still feel that we should not lose focus. And when it comes to quality assessment, quality management, and continuous quality improvement, CQI, that's also a management term. We need to make sure that we improve every day. Crowd control, overcrowding is unfortunately not an excuse. Because you know very well that crowd control, if it's not achieved, if overcrowding is the problem, then you will not achieve quality medical care. You will not provide the right quality of treatment to the right patient at the right time. Yes. So I would really implore that the management step forward and make sure that your infrastructure matches your need. Why is your need increasing? Only because you are good. You are good in delivering quality care in the wards. But if your emergency does not match, or if it's going to compromise the quality of your care, emergency care, then the primary focus of the management needs to be at developing the infrastructure of the emergency department. Continuous quality improvement is the buzzword. Sometimes, as you said, what was your quality before you had somebody qualified in the specialty, and now it probably is difficult because at that time there was no such thing as data collection. So therefore there is no research possible if there is no data collection. So but you start collecting today and do not stop. Continuously collect, continuously evaluate, continuously keep reporting so that every 6 months you have a comprehensive report on what's called as KPIs. I did not hear that term, and I'm an examiner, I like to hear certain terms. I did not hear the term key performance indicators. And unless those three words come together as a phrase, you still haven't delivered a quality lecture to me. So when it comes to KPIs, there are something where we assess this continuously by doing time motion studies. You do a lot of time motion studies. Like for example, what time does a patient come for registration? What time does the patient get seen by initial assessment? Patient comes in with a stroke. What is your door to needle time? Patient comes in with an acute coronary syndrome. What's your door to cath room time? These are called time motion studies. Time motion studies provide you with clear evidence that there is an improvement in the quality of your key performance indicators. So my suggestion, excuse me, my suggestion for you is to have more research going on in your department. It can be consultant-led, it can be done by other people. There are trainees of different sorts. Start a fellowship in emergency medicine, give them research projects to do which will assess your quality, and hopefully you will be able to start your DNB emergency medicine. You will improve your infrastructure. So that's my wish for you.
Thank you, sir.
God bless.
Thank you, sir. So, thank you, everyone.
Thank you, sir.
I would request all the moderators and the speakers to please come back on the stage for felicitation. And I would like to request Dr. Moitri Banerjee, WBCERC, to please come up on stage and felicitate our speakers and moderators.
I thank all of our speakers for their extensive viewpoints. It was truly an erudite discussion. For the next presentation of this post-lunch session, I would like to invite on stage Dr. Parthopal Sir, Medical Director of Mission Hospital, Durgapur, to share with us the essence, that is the theme of today's event, Re-Engineering Emergency Department in Peripheries for ensuring accessible, high-quality emergency care for the masses. Welcome, sir.
Slide to go to the side of that. Ready now? Very good afternoon to all of you, honored members of the commission, respected professor and teachers, respected and my dear consultants and dear friends. Actually, the vision of this conference, one-day symposium, was on the word re-engineering the emergency department in the peripheries for accessible and affordable health care. Now what my professor actually, in the year 2003, so I suppose, I was with Professor Suresh David working in the emergency, and his favorite words also in the management was re-engineering. I used the word re-engineering as transformation. I wanted a transformational change in the peripheries so that the minimum care in the golden hour can be provided to the masses. This is the main concept in which I have
framed the conference and the training also. So the most of the things like the next slide. So this is my so this is my personal experience. A 2-year-old child reported to the hospital with status epilepticus. She received a 0.5 diazepam IM in the peripheral setup. Convulsions continued. IV access could not be obtained. I gave the diazepam per rectally at the dose of 0.5 mg per kg body weight. This is in the periphery in which I had worked for 10 years in Odisha. Convulsions stopped, but the patient had episodes of bradycardia and respiratory arrest. So at that point of time, in that government setup, resuscitated with the bag and mask. Resuscitated with the bag and mask, and after 15 minutes the child cried. This is one of the case scenario which I explained, that if this minimum process can be done in the periphery nursing homes, in the periphery hospitals, so we can get a quality care. Similarly, working in this hospital also, patient reported from the Panagarh with a RTA brought by local bystander with a fracture femur and severe respiratory distress without any primary management. Patient was resuscitated in the ED but could not be saved. The patient died due to suspected pulmonary embolism. We dumped the patients in the ambulance. We dumped the patient in the local van. So this is what is the condition in which I have framed this. Next. So I'll be just going fast to the topic. The National Health Policy of the 2017 Emergency Care and Disaster Preparedness. It is a better response to disaster, both natural and man-made, requires a dispersed and effective capacity for emergency management. It requires an army of community members trained as first responders for accidents and disasters. It also requires the regular strengthening of their capacities in close collaboration with the local self-government and community-based organization. So this is about the National Health Policy. It supports the development of mass casualty management protocols for the CHC, higher facilities and emergency response protocols at all levels. The public healthcare system needs to be adequately skilled and equipped at defined levels so as to respond effectively during the emergencies. The policy envisages a creation of a unified emergency response system linked to a dedicated universal access number with network of emergency care that has an assured provision of life support and trauma management centers. And I will fasten the slide. This is the executive summary as per the project report submitted to Niti Aayog, Government of India, conducted by Department of Emergency Medicine, and Professor Bhoi was the principal investigator of this. So as per his report, the medical emergencies, including the road traffic injuries, are one of the major leading causes of death in India. Road traffic incidents alone contribute to 1.5 lakh deaths annually. Approximately 2 persons died of heart attack every hour in 2015-2016. Most of the deaths present in the emergency condition, as per one estimate, more than 50% death and 40% of the total burden of disease in low middle income countries could be averted with pre-hospital and emergency care. The emergency care system in our country suffers from fragmentation of services from pre-hospital care to facility-based care in the government as well as in the private sector. So this was the salient findings of the study, which he had already shown perhaps in today's slides. The salient findings of the study: physical infrastructure, despite the high patient load reporting to the EDs, number of beds available at the emergency departments accounted for only 3 to 5% of the total hospital bed. Most of the hospitals lack the presence of general doctors, specialists and nursing staff dedicated for the emergency department. And specifically, equipment deficiencies pertain largely to the category of the pediatric care. Since it is essential to have the complete list of all recommended emergency medicines 24/7 in the emergency departments, assessment done for this aspect revealed that all hospitals do not fulfill this criteria. Most of the health facilities lack SOPs, standard manuals for emergency care, patient transfer in and out, and handling of death. Specific protocols for definitive care for chest pain, suspected sepsis, stroke, trauma, and cardiac arrest were found lacking across the spectrum of hospitals. Financing: most of the hospitals do not have funds dedicated for the emergency care services. So some of the important key recommendations were to develop an integrated emergency care service system which can comprehensively address all medical and surgical emergencies, including the trauma-related care. Standardized protocols and SOPs for emergency care, inclusive of the triage, to have a common optimal nationwide policy. Strengthen the pre-hospital services, such as the world-class ambulance services, to be made available 24/7, encompassing our ongoing definitive care through effective paramedics for all citizens of the country. And develop a mechanism to ensure the free treatment for emergency care services for all citizens, covering the minimal required period for early stabilization. This was a report to the Niti Aayog. So main aim and objective is to deliver a high quality, low cost emergency care, ensuring affordable and accessible to the masses in periphery, identifying the current challenges in emergency healthcare education, focusing on the healthcare operations strategy, technological adoption, patient safety, clinical practice design and improvement. Aligning the nature and management of healthcare. It is uncertain. So aligning the nature and management of healthcare, it is uncertain, unreliable. Often emergency healthcare is in crisis and demonstrably expensive. Often unsafe, and less attention has been focused on the design and management of the process. So current status of the emergency care in India: emergency medical services, the ambulance, poor provision of specialized care during ambulance, no trained paramedics. Emergency care workforce lack the presence of staff in many of the emergency departments. Equipment for emergency care compliance deficiency found with availability of recommended biomedical critical equipment. Code red emergency care, because we require a hospital and system response to address immense scope improvement of pre-hospital ambulance service and emergency care, providing the high quality preventive, rehabilitative community care across the country, and to reduce the rate of ED crisis unrelated to the emergency. Adopt a crisis standard of care, thus preparing for a mass casualty incident. So emergency care to be redefined by introducing technological advancement like Internet of Health, AI-based, simulation-based education, and periphery in emergency department are to be upskilled. This is the main aim. It has to be upskilled by the knowledge, attitude, and practices, and the technical resources. So for a universal care, For universal care, for universal health care, the three important components are primary care, emergency care, and the definitive care, that is the tertiary care. Now, yes. So this is the figure, the call to action. So this is the main slide which we have planned, that working in an emergency, at least if these are the things, if it is present, for example, start with the Thomas splint, the cervical collar, the pigtail catheter, the chest tube, the laryngeal mask, LAMA, the laryngeal mask, airway, suprapubic catheter, oxygen cylinder, ECG machine, glucometer, needle trichotomy set. So these, fundamentally these things, if it is present in the peripheries of my village, if the periphery of the subdivisions, I think with the improvement of the knowledge, attitude and practices, we can improve the situation in the first step, because the advancement cannot be achieved in one day. So stepwise, if at all these peripheries can be upgraded with this minimum of instruments, minimum of this appliances are present, I think in most of the hospitals do have it, but there is a deficiency in the knowledge, attitude and the practices which we are not. The cost factors also I have tried to study, and it is not a very significant high amount of cost. So call to action, this is the thing. So we plan on hands-on the workshop, the basic emergency procedures, basic advanced life support training program, which had been for the 150 nurses and paramedics had been trained today. They are from the different parts of this periphery, starting from Purulia, from Birbhum and all. We have called most of the nurses from many of the government hospitals have also participated at the corporate hospitals. And they have been trained by the group of emergency physicians and anesthetists in the 4th floor. And we have given them with the books, basic advanced life support, and we have given on the hands-on workshop, the manuals have been provided to them. And for this, for our doctors, we have tried to plan out designing care to align the nature and management of healthcare. This is a small handbook, what we have planned, written by most of our consultants here. And this is the way the knowledge, attitude, and practice activation. So this was the main concept of this conference. Funding, despite the international recognition of importance of emergency care, essential emergency care services are not available in much of the world and receive an inadequate allocation of funding and resources. The disorganized and poorly funded emergency care system are inefficient, lead to waste resources, improvised catastrophic health spending, and significant morbidity and mortality. A growing body of evidence is demonstrating emergency care intervention to be highly cost effective. Significant further research is needed to understand the economic value of emergency care and allow for the informed resource allocation decisions. I finish my slide with this. Thank you all.
Thank you, sir, for such an wonderful speech. I would like to call Ms. Madhavi Das, ma'am, Nursing Director of Sister Nivedita University, to please come up on stage and felicitate Dr. Pal, sir.
Thank you, sir, for sharing your views. Moving on to the next topic. 21st century, or rather these post-COVID times, Our country has been all about technological advancements, ameliorating every possible industry, the healthcare industry being no exception. Cutting edge technologies such as artificial intelligence, handheld devices, data analytics have revolutionized healthcare practices, making it more accessible, efficient, and patient centric. In the words of Nelson Mandela, education is the most powerful weapon one can use to change the world. Therefore, coming up, we have a panel discussion educating us on the status of medical care in West Bengal and how handheld devices and artificial intelligence can help us improving accessibility to the medical care, emergency care ecosystem. We welcome on stage our panelists.
Dr. Sanjay S. Pawar, Principal of Dr. B.C. Roy Engineering College, Durgapur.
Padma Shri Dr. Subroto Das, CEO, Lifeline Foundation, Vadodara.
Dr. Sukumar Mukherjee, sir, from WBCERC.
Professor Dr. Raghunath Mishra, sir, Principal IQ City Hospital, Durgapur.
Ms. Ishani Chakravorty, ma'am, VP Operations from the Mission Hospital, Durgapur.
And as our moderator, we'd like to welcome on stage Justice Oshim Kumar Banerjee, sir, Chairman WBCERC on stage. Please welcome, sir.
Good afternoon, everyone. I think today's deliberation, followed by hefty lunch, everyone is in the mode of snooze. Now, let me request our senior, everybody's senior, Dr. Sukumar Mukherjee, to start the deliberation.
When we talk about the emergency medical care in rural Bengal, and there are various devices, handheld devices and artificial intelligence. Now, I have been requested to talk about the artificial intelligence. Artificial intelligence is actually, in India, is in infancy. Very few centers have started, particularly during COVID pandemic. It has been tried to pick up the pulmonary shadows, whether it is an effect of pneumonia or effect of heart failure. And that is the thing which has happened. Even if you look at the global view, very few centers have applied the artificial intelligence in critical care. But it has been of some use. I think artificial intelligence have made a major impact in the health industry. In addition to that, it is also available in commercial field, even in hospital management, even in the Air Force. And now, in intensive care unit, artificial intelligence has been tried, and there are few trials on that. And it has got many functions. I do not know whether it is ever applicable to rural Bengal, yet to start in the major cities. So obviously I cannot think of at the moment to start in the rural Bengal. But it has got some advantages, it has got some disadvantages, and it has got some shortcomings. Advantages, I can say, in the critical care, even in emergency care, you can pick up some information about the onset of cardiac arrest or respiratory arrest. A patient who comes to the emergency with some chest pain and he has got ventricular tachycardia, and whether that patient will survive with cardioversion or will it go for the cardiac arrest, that is a program that you can settle. And second point of importance, even in pulmonary shadows, a patient may come with a cough and cold and shortness of breath. And in that situation, one can think of, is it a pneumonia, or is it a heart failure, or is it a collection of fluid in the pleural sac? In that setting, if you have got the facilities for artificial intelligence, and if you have got the certain data, because it is all data-driven, as you say about the emergency care, the patient-driven, I would say artificial intelligence is data-driven. If you have got the solid data, I think you can get more information. If the data is impure, or in that case, artificial intelligence may not answer all the clinical clues what is needed. So obviously, interpretation of chest X-ray with a pulmonary shadow where there is a heart failure, we have got certain clinical clues. We have got some echocardiographic clues. We have got some information on the ECG clues. But AI may give you some limit the differential diagnosis and may give you us a clue. And that is by way of we have got two types of artificial intelligence in operation. One is the machine learning and the deep learning. And deep learning can give the information on the pulmonary shadows. Whereas in case of pre-cardiac arrest, you can get by the machine learning. Even in a patient who has got a stroke, whether it is an ischemic stroke or it is a hemorrhagic stroke, time is important. As you have heard time and again, the timely care in emergencies is very vital. In a patient who has got a headache, hypertension, unilateral paralysis, and you are thinking whether the cerebral hemorrhage, you have asked for the CT scan and you have got some anomalies. In that case, the artificial intelligence will give you an idea about the imaging, and that gives a very quick imaging report, and that gives a time so that you can give the thrombolytics in a case of ischemic stroke, and it is very, very vital to differentiate one from the other. In a hemorrhagic stroke, thrombolysis may damage the patient brain and patient may die. So obviously it is a very important decision. So in a case of stroke, signal for cardiac arrest, some cases you can go for the pulmonary opacities, and these are the emergency situation where you can get. Even in the diabetic emergencies, you can also get an idea about what dose of insulin. There are methods. By deep learning, you can look at the retina and you can forecast whether the patient has got the diabetic retinopathy much earlier than the clinical clues. I think these are some of the areas. So each has got a role for early detection, the decision making, and even intervention in emergency care. So obviously, I cannot think of AI at the moment in the rural Bengal to have, but a time may come down the line when AI will have a very great impact. But remember, AI is not a substitute for human brain. AI is an adjunct to the human brain. It is never we contest, they say that AI versus human brain. We talk about they work in combination, they can help the clinician, but there are certain difficult disadvantages about the privacy, about the regularization, about the cost of installation. All these are there. I will not go into the details, but certainly in emergency care, AI have made the impact across the globe in certain emergency situations to help the clinician, but never it is a replacement for the human brain. Thank you.
As Dr. Mukherjee has said, that AI may help us, but at the end of the day, the clinician's eye is the ultimate result. As a non-medical person, I feel so. Dr. Dash, please.
Sir, as you rightly said, after lunch, it's a bit sleepy, so I'll go and stand up and talk. Thank you. Distinguished panel members and the audience. Well, we talk of artificial intelligence as something new. But believe me, it was in the 1935 that Alan Turing first talked about artificial intelligence, 1935. And in 1960s, we come across something called the MDDS, the Medical Diagnostic Decision Support System, in the 1960s. And at that time, it was defined as something that would help simulate human learning, memory, analysis, and innovation in the medical system. So it's really not something very new. It's been there for a long time. It's just that, as I said, COVID has been pre-COVID and post-COVID our life. COVID has taught us what artificial intelligence in medicine can do. Yes, artificial intelligence can transform the electronic health records, diagnostics, medical treatment protocols. It can look at patient monitoring, robotic surgery, which we all hear about, and health system management. So a lot can be done with artificial intelligence. Where it is very significant is it has been demonstrated and documented that medical literature doubles up in 3 years. Every 3 years, medical literature is doubling, the number of literature coming out. For a human brain to analyze it would mean that we'll have to study 29 hours a day. So that's where artificial intelligence definitely has a role to play. And in medicine more so, because there are cases of overdiagnosis, like bronchial asthma in rural areas in developing countries, it's overdiagnosed 30%. Antibiotic abuse, another 30%, we do that. So maybe artificial intelligence has a role to play in those things. In India, again, this is nothing new. In 1998, a computer-assisted diagnostic system, the early detection and preventive system, was developed for the first time in rural Tamil Nadu. And a study conducted by the Kempegowda Institute of Medical Science in Bangalore showed that the overall rate of consistency between EDPS, this artificial intelligence system, and physicians was 94% for 933 patients. So it definitely has a lot of value if you look at medical infrastructures and other things. But I am not very enthusiastic about it being used in emergency medicine in rural areas, because artificial intelligence can not substitute task shifting. It can aid task shifting. And given that we are still struggling with primary and secondary care in rural India, with low public health spending, low coverage of health insurance, lack of training for health workers. Let's take West Bengal. I am a Bengali, I haven't stayed here though, but if you look at the 23 districts of West Bengal, it performs like many other states. A total of 1,356 PHCs, and 68.13% of the population lives in rural areas in Bengal. A subcenter is the first point of contact. 6 subcenters go to a CHC, and then 6 subcenters go into a PHC, and then 4 PHCs go into a CHC. That is the usual structure. So what do we have here? 37.7% of PHCs in West Bengal do not have a doctor. West Bengal is one of the 10 states with that sort of a record. Madhya Pradesh is the worst. All the community centers in Sikkim, for example, and 94% of community health centers in Madhya Pradesh don't have a specialist. A CHC is supposed to have 4 specialists. In West Bengal, 79.6% of CHCs do not have a specialist. There's a nursing staff vacancy of 1688. So for me, I don't think artificial intelligence in EMS in rural areas is a factor that we can still look at, because we need to develop primary care, we need to develop secondary care. That is where artificial intelligence can still make a lot of difference in primary care in rural areas and not EMS. Because we need to first look at delivering primary care and then going into EMS. There are major barriers that we need to understand in rural areas. Just giving a handheld device does not make it artificial intelligence. You have to have a support system, a continuous updation of the systems, continuous training, refresher courses, retraining people, back-end, a lot of repository of data. That unfortunately has not been built. And worst scenario that I experience with the ambulances when they carry the handheld device, if a paramedic doesn't know how to use it, the entire system collapses. And when a paramedic does not turn up for duty, another person comes in to fill in, he doesn't even have the password to use that. So there are lots of difficulties that taking handheld devices, laptops, iPads and everything in rural India is going to be a challenge. Also the same in West Bengal. Thank you.
Dr. Pawar.
Hello. I think I'll be comfortable here. Listen from the speakers and experts. I'm not a doctor, I'm an engineer actually. Of course, there are a lot of pros and cons with AI. I'm a practitioner of AI. Again, almost all of us are using the word called as a digital transformation. I'm practicing digital transformation, but not from the medical point of view, but has done some kind of research from medical with my students also, using AI. So the concept that you are using deep learning, where CNN, specifically convolutional neural network it is called as, most of the diagnosis, CT scan, or whatever the disease of pneumonia, etc., I have worked with my student to detect the X-rays where it can deviate or differentiate between different kind of diseases and so on. So this is a real practice, worked personally on that and so on. So rather than assuming certain things, first of all, what all of us should understand is, AI means first of all, literally understand what does it give. What are the things? As sir said, a lot of things. In fact, AI has been there since last maybe 50 years. I learnt one of the subject called artificial neural network in 1998. And then in between it was blocked because of some things or not availability of certain devices. Now the things have changed. The technology has changed. Now when AI means it is supported with the other technologies also. What are the other technologies? One is 5G is coming into picture. So what is it? AI means what is you have a data and processing of data. As sir said, infinite data is available. In present also the same system is there in case of companies as well as in medical sector or as a health sector. First of all, to effectively utilize this data or AI, you should generate a data. You should start storing the data. You should start utilizing the data. That's what sir said. Whatever the data is there, I think presently it is on a paper or it is stored in a database or maybe a terabyte or whatever. But are we utilizing those things? AI is depending upon what is the previous data, how do you train your system, and how it is learning. That's what machine learning and training. Are we using our data for training some of these cases? Presently, I don't know actually those things. So the effectiveness will come into picture more when you start utilizing what are the data are there. Now various sectors are there. Though as in, sir also said that whether it is useful in private sector or whether it is in rural Bengal or in a maybe a corporate sector, or maybe in a metros and so on. It's not the cases. There will be some kind of examples where the kind of the diagnosis and the kind of services that are there in the metros may not be possible to reach you to the rural part. So in such scenarios, I can carry certain infrastructure, have a connectivity at the metro center, have a diagnosis done, or transfer the data. That's what it said. It's not only AI technology, but the supportive mechanism comes into picture. There is also a concept called as the edge computing, which is really important nowadays. The effectiveness of AI comes into picture when you compute your data very properly and effectiveness and so on. So presently what happens, as an example, let's say all of us look at this Amazons and Netflix. So presently whenever the request goes, it goes to the server, etc. and so on. But when effectiveness has to be increased, if the computing is at the local places, then the diagnosis, the results will come into picture. I'll tell an example also. Let's say in emergency services, something happens, people come into picture for the treatment, and then you start taking the data or maybe some kind of a test. Feeding the data to the test, manual version, or nowadays we have some kind of a devices which are again Bluetooth enabled or a Wi-Fi enabled. I need not convert, read, etc., but it is automatically connected to my devices at the server, and it goes into the repository. At a backend, this data is read, analyzed, and the result is sent immediately, etc. and so on. This is what the things are being practiced. It's not in a notebook, or it's not the case that it is there, but this will be there, and in future, most of these things will be a part of a system where, as Sir also showed, it's not only from analysis or diagnosis point of view, but operations, optimizations, efficiency, accuracy, all this matters, and in almost all cases, some or other kind of algorithms will be used and so on. As I am from engineering, as I said, what are the algorithms, which is for which purpose, that I well known. So effectively, again, just because AI, I should use AI in everything, that also doesn't matter. Where and how it perfectly meets, that also matters and so on. As I am also part of maybe designing and developing some kind of a ERP with mission hospitals. So presently we are collecting the data, and after collecting all this data, we'll be embedding the algorithms to have an intelligence from those data. Because gathering the intelligence from data and feeding to the system and taking a decision, this matters a lot and so on. And this is what the concepts are there. So connecting, or for example, we might have, almost all of us are hearing the case of robotic surgeries, etc. and so on. So in this case, robotic surgeries are there, but it is supported by, again, the AI, it is supported by the communications, which is a 5G, it is supported by edge computing, everything and so on. If this would not have been there, of course, the treatment that is expected at a metros would not have been possible in case of a rural or whatever things are there. So the combination of the devices that are available and the backend servers, and nowadays I think most of you are doctors here, you can see there are infinite services available as the .ai services. And almost many of the companies, tech companies, are earning a lot on diagnosis on this basis. Because the reason is, the data is fed to them, they have an analysis done, only reading of the data and result, and then fine tuning is done by human. It is not final results or decisions are not taken by the machine itself, but it is done by a doctors, etc. and so on. And this would help in taking a decision, accuracy increases, efficiency increases, and as a part of emergency which requires a right decision in a less amount of time, this would help these things and so on. This is what I would like to say from this point of view. Thank you.
Thank you, Dr. Pawar. So, listening to Dr. Mukherjee, Dr. Das, Dr. Pawar, although Dr. Pawar says I am not a doctor, but at the end of the day, the human brain is the ultimate decision maker. That everyone would agree. Now there are, as Dr. Das has said, that West Bengal is lacking, so far doctors are concerned. In rural Bengal, there are health centers where doctors are not there. And he has mentioned about Madhya Pradesh. So where these problems were there, and if there is actual help from the concerned experts who would feed the data and there to take advantage of the data in those places where the doctors are not available, like telemedicine. So that would be better. And I cannot check my temptation to share, digressing from this, that Dr. Power was saying robotic surgery, as I have understood. The robotic surgery, the best part of it, that it can rotate 360 degree, where human hand cannot. But if you remember 1972 cricket match in Eden Garden, where on the 4th day everyone was definite that India is going to lose. But the Chandrasekhar, that bowler, he has his disability because of polio, he has utilized it and his hand has played a role that India won that match on the 5th day. That is in 1972. Tony Greig was on the screen. Because his hand rotates more than what a normal hand can rotate. So these are benefits we can achieve. We can take from artificial intelligence or the advancements of science. But it has to be used by people with adequate expertise. Dr. Misro.
Very good afternoon. Actually, here, our rural Bengal, the health emergency service status and the utility of handheld devices and AI, artificial intelligence in this purpose, it is very important in this era. Actually, in rural Bengal, you know that not only rural Bengal, in India, we have the center, health center, to provide the primary health care to each and every individual in the country. But there are some paucity of our infrastructure, paucity of our human resource, and also paucity of our knowledge and skill. In this regard, when any emergency cases in the rural area, then there is no alternative way, that is only a way to treat the cases within that health center first, and then ultimately that is referred to higher center, and golden time has already lost. So many deaths are occur due to such delay, and for that delay we are losing so many lives. So here, in this case, our handheld devices, during the last few years, this delay has drastically reduced. As you know, that only by use of mobile phone, many deaths has been averted by timely the news and information to the center about the incidents. Again, by proper use of artificial intelligence, we can change the situation of our paucity and lack of our human resource by using properly this artificial intelligence. As you know, that our every health center, every institute is in lacking of radiologists. And these radiologists, now we can use this artificial intelligence to make this particular gap, and that gap can be by our artificial intelligence. And as Sir very nicely presented, that our so many day by day we are changing due to our research and our invention. The medical field is gradually increasing, and that particular research, we can't go through all the research. and by artificial intelligence it can be improved. So our human brain and also by proper use of artificial intelligence, we can change our system within the rural India up to our village level. And nowadays, if you see, even our Asha Kormi, who are using such devices, and they are giving so many drugs, and also they are advising that this may be such type of disease, and you have to go such center for proper investigation and proper management. So our handheld devices and artificial intelligence will change our health status in future.
Dr. Misro has very rightly said, but possibly we have mixed up with artificial intelligence and communicating system. Communicating system is really helping us, but artificial intelligence is something, it cannot act as an equipment. It has to be through a machine, and there must be a man behind the machine, and that man must have proper expertise. May I request now, the time has come to listen to the administrator, the Vice President Operation, Madam Chakraborty would address us on the issue.
Thank you so much, sir. You rightly said, I'm neither a doctor nor an engineer. I'm an administrator. And let me tell you, it has been absolutely an audacious move to have agreed to participate in this panel discussion with such stalwarts sitting around me. I'm lost. AI has been spoken at length with all its aspects, the use of AI in medical sciences, the pros, cons, debates, everything. I will not delve into it. What I understand of the topic today is there is a population in a remote corner, inaccessible, with the kind of healthcare services that we are providing in the tier 1, tier 2, tier 3 cities. We need to reach out to them. And can technology help us in reaching out to that population, to those people? There is an advantage of speaking last, obviously. I can pick the tail and sail through. When I started my career about 2 decades back, telemedicine was in vogue. But then telemedicine was kind of a video call, which we see every now and then today. Our family members staying in USA, we just make a call and talk. That was the telemedicine that was there, and all the ECG, echo, and all other reports used to be faxed. Now it has become much, much more advanced. There is digital transmission of all the reports. But when we are talking of the population in the remote areas, let me just give a small statistics that was published by Niti Aayog in their report of investment opportunities in India's health sector. It was published in 2021, where they are saying in West Bengal, each sub-center covers a population of 5,000 to 7,000 people. That was on 31st of March 2020 statistics. A PHC covers 50,000 plus population, and a CHC, that's the community health center you all were talking about, it covers about 1.2 lakh population. And rightly mentioned by Dr. Subroto Das, the statistics that's been published by Niti Aayog also mentions that there's a huge scarcity of resources. When I was doing my post-graduation, I used to take up part-time jobs with SUDA, State Urban Development Agency in Kolkata. And I did a project for upgradation of the primary healthcare system funded by GTZ, German Technical Cooperation. My job was to go to the PHCs and the SCs and find out the needs that need to be funded. So I went to these remote places, remote villages. I looked at those hospitals, barely a hospital, a 12-bed hospital or a 10-bed hospital. There was a lab, but there wasn't equipment. There wasn't reagent to run the tests. There were hardly any specialists. There were lack of resources. This was 2 decades back. I don't know the scenario today, but I don't think it has changed drastically. We still need to reach out to them, and I strongly think technology can be that conduit, can bridge that gap. I agree with Justice Ashim Banerjee, sir, that there has to be a human brain behind every development. There has to be the human mind, but that human mind is always there, and these technologies are coming up because there is this human mind. At some point of time, we could not think of a smartphone, could we? We could not think of making a video call. We could not think of doing everything through our phone. But today we are, and everybody, including people in the remote villages, have a smartphone. But let me tell you, that has also become a story of the yesteryears. Today's latest story are wearables and implantables. The wearables are those smartwatches, which everybody is having on their hand, which just about does anything. It measures your steps, it measures your blood pressure, it measures our SpO2, everything through a smartwatch. And there are implantables. 2 weeks back, I was watching the news in Vantage. I was surprised to see a news that a 70-year-old lady who had paralysis and was not able to speak had a microchip implanted that reads the brain waves of the thoughts going on in her mind and converts that into speech. This is in an experimental stage, but definitely if this is in the experimental stage and the brains, the human brains that are working behind this will make it a reality one day. Like it has made the smartphones real, like it has made the devices real, like it has made so many other biomedical equipment real. It has made the PACs real. Like in remote villages or even during holidays, the doctors can check the medical condition, the vitals of their patients just through an app. They can check the CT and MRI reports and can write back and give instructions to their RMOs, the juniors, and the nursing staff from anywhere, absolutely anywhere in the world. So this is where I think technology can bridge the gap. I think AI has a huge role to play in the coming years. All these debates, they are there, whether it is good or bad, I don't know. I'm not so much conversant into it, but I just keep up with the technology that is coming up. And I think even if I like it or I do not like it, it is here and it is going to sweep us away to a next tomorrow. It's going to take us to the tomorrow even if I don't like it. So I think let's make the best of it. Thank you very much.
To sum up, I would say, I remember everyone has watched 3 Idiots, the use of the video call and where doctors were not available. Madam has said that now smartwatch can tell you how long you have walked from today morning, what is your blood pressure, everything, but how far you would trust your smartwatch. Would you trust this smartwatch or would you trust the physical examination by Dr. Sukumar Mukherjee? Future would give the reply. And please, I would request to read the article, the caution note of the inventor of AI, which has come out in the newspaper, because he has keeping his finger crossed. the, the problem with AI and the problem with AI that might create havoc or disaster, as I say, disaster in future. Thank you all.
Thank you everyone. I would request all the moderators and speakers please be on stage for felicitation.
I would like to request Dr. Parthopal Sir, Medical Director, to please come up on stage and felicitate Dr. Sanjay S. Pawar and Professor Dr. Raghunath Mishra, as it could not be done before.
I would request Professor Dr. Suresh David, sir, please come up on stage and felicitate all our moderators and speakers. Thank you, sir and ma'am. Moving on to our next topic of discussion is emergency physicians' role in stroke and trauma. Emergency and pre-hospital care, that is emergency medical services, are the primary point of contact for a patient who is in need of immediate care. Especially in cases of stroke, whether it is cardiac or cerebral, and trauma, there exists a concept of golden hour. In today's scenario, every second matters. This is the place where an emergency physician takes a stand about emergent assessment, stabilization, decision making, mobilization of resources, and disposition. Even though every patient management in an emergency care setup requires a team endeavor, it is the EP who decides the involvement of concerned specialists. So in this session, we are having skilled emergency physicians from reputed institutions who will define the role of an EP in these scenarios. And in panel, we have renowned specialists encircling orthopedics and neurosurgeons. So calling upon stage, Dr. Kishan Goel, Assistant Professor, Department of Emergency Medicine, IPG, MER, Kolkata.
Dr. Shomitra Thanda, Sir, Consultant Emergency Medicine, Mission Hospital.
Dr. Nirmal Kumar Jajuria, Sir, Senior Consultant and Orthopedic Surgeon of the Mission Hospital, Durgapur.
Dr. Satyajit Das, Sir, Senior Consultant Neurosurgeon, Mission Hospital, Durgapur.
And Dr. Rahul Bose, Sir, Consultant City Base from the Mission Hospital, Durgapur.
Where is the slide? Sir. This is
Yeah.
slide change on this one. Good afternoon, everyone. Thank you. First of all, I'd like to thank the organizer for giving me the opportunity to speak on this platform. Today, I'll be discussing about the role of emergency physician in stroke. So starting with what is stroke? It's a time-sensitive medical emergency. It is defined by WHO as a rapidly developing focal or global loss of cerebral functions which lasts for more than 24 hours, and it must be of vascular origin. So basically there are three types of stroke. First, most common is ischemic stroke. The second most common is ICS, the intracranial hemorrhage, which can be of various types like ICH, EDH, SDH. And the third one is CVT, cerebral venous thrombosis. So now coming, what is the role of EP, emergency physician? Basically stroke, when the stroke comes, everyone thinks that it's a neurologist is needed immediately to take the decisions and manage. Basically it's a teamwork. The emergency physicians are the first person who get contacted with the patient when the person arrives to the hospital. And he's the person who will start the full protocols and the things and the step by step. So basically there are several rules. First thing is the recognition of the symptoms, whether this is stroke or something else, whether it's a hypoglycemia or it might be a syncope or vertigo. The second thing, once he recognizes this is a stroke, you need to activate something which is called stroke protocol or stroke code or a stroke pathway, anything. Then focus history taking, the initial examination and the stabilization, the rapid imaging, and the definitive management with the help of a neurologist, and monitoring of the patient vitals during the thrombolysis or the EVT. So coming to the first one, recognizing the stroke, basically you should always have a high degree of suspicion that this patient might have stroke. So there is something mnemonic like be fast, like loss of balance, loss of vision, any facial deviation, arm weakness, or difficulty in speech, we need to always think that this patient might have stroke, and we should always activate our stroke code in the ED itself. And after that, a focus history has to be taken, like when the system, when there was this paralysis got started, when the symptoms have come, what was the last seen normal, what medications he is taking, whether any anticoagulants, antiplatelets, or any cardiac disease, any congenital heart disease like VSG, ASG, something is there or not, or any risk factors like smoking, hypertension and all, diabetes history has to be taken. Then come to a rapid clinical examination, all the vitals, and we need to calculate GCS and NHS score. Based upon the NHS score, we will divide the patient into no stroke, moderate stroke, mild stroke, or a severe stroke. And with all these things, we will respond. After that, the most important part which comes for the EP is stabilization of the patient. All stroke patients will not be hemodynamic stable or routine thing. So we need to stabilize the patient. With this stabilization comes the ABC, the airway, breathing, and the circulation. Some stroke patients might have increased raised ICP features, so we need to control that. The airway is compromised, so we need to do a rapid sequence intubation, and that has to be done with the reagents which decreases the sympathetic drive and does not causes increased ICP. Because great skill is needed to intubate a stroke patients with all these complications. Then some ventilator strategies we need to perform, like if the patients have high raised ICP, then hyperventilation has to be done. We need to put all the invasive lines like central line or IV line, whatever is needed That time only, because once we have done a thrombolysis, if this patient is in window period, we can't put that invasive lines. That will cause a lot of bleeding and all. So that decision has to be taken prior on. Then comes the blood pressure control, the most important thing. Based upon if the patient is eligible for thrombolysis, we will target for 185 by 110. If it is not, if no thrombolysis, then we will target blood pressure of less than 220 by 110. Various agents are used like labetalol, Nicardia and cilnidipine. Based upon the responses and the indication and contraindication, we will choose our drugs. Post this, we need to go for a rapid imaging. Like urgent CT scan has to be done. So this duty is of the emergency physician to get this scan done. Because if we send the patient like this to a radio department, there will be a lot of patients waiting there for other scans, and this patients will get delay. So it's a duty of the EP to get contact with the technician or a radiologist who is available that moment and make it a speed fast. So this imaging is done on the priority basis. Normally we start with a non-contrast CT, and after that followed by a CT angio to plan for any invasive procedures. So these are some early signs like hypertension, MCA sign is there, or MCA dot sign, obstruction of lentiform nucleus, loss of insular ribbon. These are the early signs, and the late signs are hypodense area representing the infarct. In CT scan we can get for ICH also, then we'll go for the ICH protocol. So there are some goals of management. Immediately once you have recognized the patient is having stroke, you should always activate the stroke team. So stroke team consists of an neurologist, neurointerventionologist and a radiologist and critical care physician also. Then we'll start with brain imaging, which has to be done within 20 minutes. Then we need to interpret the brain imaging, which has to be done within 45 minutes. And if the patient is eligible for thrombolysis, it has to be done within 1 hour. Like door to needle time is 1 hour. Then additional investigation like random blood sugar to rule out hypoglycemia, INR, platelets and ECG has to be done. Then we come to a definitive management. Once we have diagnosed the patient is having acute stroke, with the help of a neurologist, whether he is present on board or we can take a neurology consultation with all the scans and the history and the NIH score, and if the patient is eligible for thrombolysis, we can plan for thrombolysis because all the RCTs have shown it has improved the functional outcome. So various agents are used, most commonly is alteplase and tenecteplase. Doses are 0.9 mg per kg. We need to give 10% bolus followed by a 90% infusion. And during this time, the most important role which is played by EP is now the monitoring of the BP during the thrombolysis period. The first 2 hours, it has to be done every 15 minutes. Then 3 to 8 hours, it has to be done every 30 minutes. Then 9 to 24 hours, it is be done every 60 minutes. And we need to target the BP whatever our goals is there. Otherwise, there will be a risk of IC bleed and various other complications. So this is the flow chart. This is the flow chart which shows the same thing. When the patient comes with the signs and symptoms suggestive of stroke, we will see whether it's less than 4.5 hours or more than 4.5 hours. If it is less than 4.5 hours, then we will get an immediately CT scan done, followed by a CT angio. If the patient is eligible for thrombolysis, thrombolysis will be given. And once the thrombolysis is given, then the patient will be taken to the cath lab if the required an endovascular therapy or something. If it is more than 4.5 hours, then and within 24 hours, then we need to go for something which called an MRI for a diffusion scan to find out whether there is any eligible area or not. After that, we'll take a decision whether this patient will require any invasive procedures or not. More than 24 hours is managed, normal conservative management is done. And there are a lot of contraindications for doing thrombolysis, which is written. Another subset of stroke is ICH. In that normally, so basically the NCCT brain is done just to rule out ICH. If that is there, we'll do our same ABC protocol, correct the blood pressure. If any coagulopathy is there, like patient is on anticoagulants or antiplatelets, so that reversal agent has to be given. This all decision will be taken by the EP, the emergency physician on duty that time. The seizure control, the control to decrease the raise ICP features and all. Why the management of the stroke is time sensitive? Because the stroke is a medical emergency. With every second, the neurons start dying. The data shows that 3,200 neurons dies within per second, and each stroke there is a loss of 1.2 billion neurons. So basically, we need to decrease the delay. So in hospital there should be a triaging. Like during the triage time only, we should find out this patient is having stroke with our BFAST protocol. Once the stroke is diagnosed, we need to activate the stroke protocol. And we need to sensitize all the staffs of the emergency, the technicians, the radiologists, and the nursing people. What is the importance of stroke and what is the time in this? So once you have think that everyone is sensitized, then they will start act fast. The sisters will start measuring the BP, secure IV line, all the NHS score will be calculated, the radio department knows that the stroke code has been activated, the patient will be coming, the same code will be sent to the radiologist. Radiologist also know that he need to interpret this CT scan immediately. The same when the code stroke is active, the neurologist is also been alerted, the neurointerventional radiologist is also been alerted. Everyone is on board at that time. So as much delay is possible, we need to do it very fast. So basically a local stroke code has to be formed. So now there is a concept of pre-hospital notification. If we have a proper EMS guy who knows how to diagnose stroke, once he has gone for an ambulance call, in ambulance only he might diagnose that this patient is having a stroke, then he will inform the emergency department that I am getting one code stroke patients, kindly prepare everything, so the delay will be less. So nowadays a new concept of mobile stroke unit is also coming up, in which we have a CT scan machine inside the ambulance. So there the CT scan can be done in the ambulance and the decision can be taken there only. So thank you.
Thank you, Kishan sir. So, very good afternoon to all the chief guests and my senior colleagues. So, I'll be discussing the emergency physician's roles during the trauma management. So, today we have a very fruitful discussion regarding all trauma-related, non-trauma-related emergencies and what is the burden of trauma. We also discussed with figures and all. So during management of trauma, we initially go by the ABCDE, that is the airway with the cervical spine control, breathing and ventilation management, management of circulation and hemorrhage control, and disability with assessment of neurological status, and lastly E, that is exposure with environment control. This is the primary survey, that is followed by history taking and secondary survey. So in primary survey, we generally take care of the life-threatening conditions and we try to normalize the physiology of the patients. And it is not, we usually do it rapidly. So it is very important to stabilize the physiological status and not to look for the anatomical injuries that can be looked during the secondary survey. So in the trauma management is usually a team approach. During a trauma team, generally the airway part is taken care by the emergency physician, and we also have a trauma surgeon or general surgeon taking care of the circulation part, and a orthopedic surgeon taking care of the splinting and extremity trauma. So the emergency physician role is mainly during the stabilization part, airway management, and after consultation, what is the, after taking care all the injuries and investigation, what is, if there is any need of thoracotomy or any need of any neurosurgical intervention, so that is the definitive care. So this sort of consultation, when to take this consultation is part of the emergency physician's part. So, so Dr. Satyajit Das sir, my question is to you, sir. What is the role of anti-epileptic in nowadays in traumatic brain injuries? Can you please explore on that?
First and foremost, I would like to just starting from your discussion and then go up to his discussion. In the clinical assessment, first and foremost, the primary aim and objective of assessment should be that if it is an emergency situation where a decompression needs to be done, either surgical or medical, that has to be decided as early as possible and the definitive management started. Because time is brain. So that is the tagline, time is brain. So we should not waste any time. Now, there are a few, when the patient arrives to you, when you do the clinical assessment like you mentioned, you missed out on one very important point, is checking the pupils. So if there is, you see there is a pupillary asymmetry, then immediately you have to think that probably there is an uncal herniation taking place and this patient requires an urgent decompression. And then obviously you get an imaging done as early as possible. So in our neurosurgical practice, there was an era before brain imaging and there is an era after brain imaging. So before brain imaging, everything was based on, clinical assessment. Nowadays, along with clinical assessment, all our treatment protocols is dependent on the imaging. So on a CT scan, what do you see? If you see, obviously there is a very big hemorrhage or there is a large ischemic stroke with a midline shift, or there is a hemorrhage which is more than 50 or 60 cc in volume, or more than 50 cc in the temporal lobe, or more than 3 centimeters in the posterior fossa. That means that immediate surgical decompression has to be done. Or your anti-edema measures need to be super, aggressive, because the patient can herniate any time. And the patient might become brain dead before you can do anything about it. So, coming to the basics of treatment, again, obviously you will go to the anti-edema measures, the brain protective measures, will take care of enough adequate oxygenation. Again, blood pressure control, you would want to see how much blood pressure do I want. Do I want normotension? Do I want hypertension? Do I want hypertension? So you go by the baseline. First and foremost, we must ensure that there is adequate perfusion to the brain. So you need at least normotension or slight hypertension. But then if it is an ischemic thing, then you have to go for hypertension. If it is a hemorrhagic stroke, we don't want too much of hypertension, then the bleed might increase in size. So that is the BP control, and you need to decide about that. And then if you come to anti-epileptics, there are a lot of controversies in the use of anti-epileptics, what is there present in the literature and what we do in real practice. There are a lot of decision-making process. It is not, I will say, a very important part of the treatment per se. Obviously, if a patient has come to you who is having active seizures, then your anti-epileptic management has to be very aggressive. Your decision regarding what anti-epileptics you are using is again based on your institutional policies and the present guidelines. So the time-tested anti-epileptics like phenytoin and valproic and carbamazepine, they are always there and they are the first-line drugs. But the newer medications like levetiracetam and brivaracetam, they have proven to be much more safer in terms of their pharmacological properties and interactions and side effects. So they are also in use right now. For example, if a patient has come to you with liver failure, obviously you cannot give phenytoin. So our first line of management will be levetiracetam. So if somebody has come with active seizures, definitely we'll start antiepileptics. If somebody does not have active seizures, then antiepileptics is not that important, but prophylactically, yes, there is something called an early post-traumatic seizures and there is something called late post-traumatic seizures. So antiepileptics have been found to reduce the risk of early post-traumatic seizures. So it is recommended nowadays that you start a prophylactic epileptic, whether it is phenytoin or whether it is levetiracetam. But it is not that much useful. So if the patient is not having active seizures, if the CT scan is more or less normal, you need not even start antiepileptics. But if there is a contusion or a depressed skull fracture, or if there is a venous sinus thrombosis, especially involving the temporal lobes or the insular area or the frontal lobes or the areas around the motor cortex, these are highly epileptogenic zones. And in these cases, you will have to start antiepileptic prophylaxis.
Thank you, sir. So now coming to the one again area of controversy, like I will ask Dr. Rahul Bose, sir, to the indication of emergency thoracotomy and what is the and please sir explain on that and the next question.
Good afternoon. Sorry, good evening. So I think the indications for an emergency thoracotomy are very clearly defined in all of the textbooks. You put in the drain and then I think 1000 to 1500 ml immediately comes out, you open up. 200 ml per hour for 3 hours comes out, you open up. So those indications are very clearly defined. However, and this is what I have seen in my practice, both during my time in Kolkata as well as over here, that 80% of the cases usually resolve by just putting in a chest drain. That is all you require. And if there is something gross, like, you know, there is a penetrating trauma in which, you know, there is a definite history in which somebody has shoved a sword inside the chest, that is the only reason that you actually, or, you know, there is a bullet injury and you can see that there is a, you do a chest X-ray and you see the bullet fragments in the chest and there is no exit wound. So those are the cases where you actually, I feel, you need to open up and explore. Small bleeds, they usually, you know, they close by themselves. Unless there's something gross, there is no need to do. And, you know, things which have been described in textbooks like clamshell thoracotomies and all of that, that I do not feel is required. Thank you.
Thank you, sir. And so my next question to Dr. Nirmal Judia, sir, regarding the current management guidelines of pelvic trauma and unstable pelvic fractures.
So, in terms of emergency care where an orthopedician would be needed, I think that is the most significant emergency, orthopedic emergency, because the pelvis is an organ where there are so much of veins and so many arteries around it, that the commonest cause of death because of a pelvic trauma is because of hemorrhage. Like any circulation maintenance, you have to give a fluid challenge and you see that whether the patient is responding to a fluid challenge. Of course, you should have ruled out any other hidden cryptic hemorrhage, like either in the chest or in the abdomen. If the chest is okay and your abdomen is okay and your pelvis is the only source of bleeding, immediate pelvic binder at least helps to, even a sheet applied in a manner, double folded manner with 2 towel clips to stabilize the pelvis and then give them adequate fluid, adequate blood products, and then go to the imaging. It is important to image the patient immediately, do the trauma series to see what is the kind of fracture that you are dealing with. Because all pelvic fractures do not bleed that much. There are stable varieties and then there are unstable varieties of pelvic fractures. So if you are encountering an unstable variety of pelvic fracture and you are not adequately able to resuscitate the patient by good amount of fluid and blood products, that is the time to consider an emergency surgical procedure for the patient to stabilize the pelvis and to do some pelvic packing in terms of just do a phanestoid incision and pack the pelvis like you do in gynecological hemorrhages and all that. And most of the times the pelvic bleeding is usually either venous or from the blood, from the pelvic marrow, and it would respond to pelvic packing. If the patient, in spite of adequate resuscitation and packing, doesn't still fail to resuscitate, still fail to stabilize, probable cause is an arterial cause. In that case, the next thing you will ask for is a angiogram to see what is the source of the bleeding. And if you are encountering a bleeding from the artery, either do a thromboembolization by the endovascular methods, by coiling, or go in and explore and ligate the artery. You know, that is in a nutshell how you'll address a pelvic injury.
Thank you, sir. So actually we are running quite late on our presentation, so we'll go to the next presentation. I will like to invite on the stage Dr. Priyanshi Chatterjee to show some lights on ophthalmological emergencies and what they present in emergency situation.
I would like to thank the audience for such patient hearing. It's been a long day, and I would run the presentation as soon as I can. Just a short presentation on the common ophthalmic emergencies. Just a quick reminder that Indian Penal Code defines grievous hurt, section 320, and one of the points in that is permanent privation of the sight of either eye. So if due to your negligence the patient loses sight in either of his eyes, then this is considered a grievous hurt. Quantum of punishment can be up to 2 years. Sorry for that gory detail, but just to get your attention. Ophthalmic emergencies might not seem very important, but because of the fact that it involves sight, it carries some importance in the ER. And most of emergency services today are not really equipped to handle ophthalmic emergencies. So, and the problem is that after 5 p.m. you're going to find colleagues of every other department, but you're not going to find your opthal colleagues, because they are in the beach. They are not trained to work after 5 p.m. So you'll have to handle whatever happens for the next few hours until you can refer the patient out the next day. So the most common problem, the most common type of emergency is of course trauma. Eye trauma, most commonly fist injuries, road traffic accidents, fall on the ground, and all of these things comprise trauma to the eye. The most important parameter that will determine the prognosis of the patient, of how soon the patient is going to recover, as well as how liable you are to medical lawsuits, depends on whether the globe is intact, whether it's an open globe injury or a closed globe injury. So to determine that is step number 1. So Birmingham Eye Trauma Society classifies eye injuries into open globe and closed globe injuries. And in open globe, there's penetrating, perforating injuries, ruptures, foreign bodies, and all of that. So few things to safeguard yourself from medical legal trouble. There are a few documentations that are very important when you see a case of an eye injury or any eye emergency. And if you can document these, then you're safe. So one of them is to understand how to take vision, how to record vision, very, very important. So this small video to demonstrate the same. the ER won't have a vision chart. So you will start by counting fingers. You will start by showing your fingers at 3 meters, see whether the patient can see it, then go to 2 meters and then 1 meter. And if your patient can't identify the fingers, then you do hand movement examination. I'm sorry, the video is not playing for some reason. So you go close to the face and you move your hands, that is the hand movement examination. And if your patient can't see your moving hand, then comes the trouble, then you have to assess whether the patient is being able to perceive light at the initial point of examination. This is very important. PL, perception of light. You have to determine whether the patient is able to see light when you have started examining. So darken the room, that's ideal. Torch light with a bulb torch, not an LED torch. One eye at a time. Focus the torchlight on the patient's eye and see whether the patient can identify the source of light coming. If the patient can see light, you have to determine whether they can see the light coming from every direction. Very, very important. I'm sorry, the video is not playing. The next and very important thing is to determine whether you have a relative afferent pupillary defect, whether patient's pupils are constricting and dilating as it should. This is the RAPD, very important to elicit this and document it if RAPD is present, which means that the optic nerve function has been damaged when you have examined the patient. So this brings to an end to injuries. If it's a closed globe injury, you don't have much to worry, except that you have, if the patient is screaming in pain, if the patient is having severe eye pain with vomiting, headache, nausea, then you might be looking at a raised intraocular pressure due to hyphema or other trauma. So checking the pressure digitally, just compare the pressure of the injured eye with the normal eye. If the eyeball feels a little harder than the other eye, then the pressure is raised. If the pressure is more than 40 millimeter of mercury, patient is going to have severe pain. You have to start IV mannitol or oral acetazolamide to relieve that pain. Otherwise, they won't go through the night. It's a severe, very severe pain. The next is an open globe injury. If you see that there's a perforation, the eyeball has collapsed, please do not administer any eye drops or medications. They are all retinotoxic. So you should not give any medications in an open globe injury. Just patch the eye. If possible, do an MRI or a CT scan. It'll help the treating surgeon the next day, and just refer as soon as possible. The main idea is to close the globe as soon as you can. Next is chemical injury, also a very important medico-legal case. You must check the pH when you start examining the patient with a litmus paper, very, very important, and document that. Keep that pH paper with your file. And after giving a thorough eye wash with normal saline, you have to, at the end of that eye wash, again check the pH to make sure that it has neutralized. Eversion of the eyelid when you give the eye wash is absolutely necessary. Because a lot of foreign bodies like tuna powder gets dislodged there and causes great damage. So the reason why we give eye wash is not to clear the eye of the chemical that has gone in, but the chemical that went in started penetrating into the eye, and when you have examined the patient, the anterior chamber pH has changed. You're normalizing the anterior chamber pH, which is why you're giving the eye wash. The next very common sudden monocular painless loss of vision, central retinal artery occlusion, medical and general emergency. You have a 100-minute window before the patient loses sight forever. There's not much you can do, but you can decrease the intraocular pressure by giving oral acetazolamide and an ocular massage, which may sometimes dislodge the emboli. Very important to evaluate these patients for giant cell arteritis, endocarditis, thrombophilia, and a carotid artery embolism. These things have to be, the stroke team has to come in and evaluate these patients, otherwise you're looking at a second episode of stroke very soon. In 25% of the patients, the patient is going to stroke out again in a few days. So this is how you give the ocular digital massage. Just press on the globe very hard and release it suddenly. Keep doing it a few times. You may have dislodged the emboli. And the retina on the top picture is when you have an artery occlusion, it becomes white. So as soon as it starts getting perfused again, you will see that the normal color of the fundus returns. So this is raised intraocular pressure, acute angle closure attack, also treated similarly like how you have to decrease the intraocular pressure. This is a case scenario, 12-year-old boy in the emergency, complaining of pain, blurred vision, swelling in the eye, antibiotics had been started. There are painful eye movements. Any idea in the audience what this could be? Okay, everyone is too sleepy, so I'll just say that this is orbital cellulitis. It is an emergency. When children present with swelling in the eye and painful eye movements, this is an absolute emergency because it can easily cause intracranial extension, meningitis, and several other problems. You may lose the patient. So please start IV antibiotics, ceftazidime as the drug of choice. Please start immediately. And don't get confused with preorbital cellulitis. Looks similar, but there is no pain on eye movements. So this is the main differentiating feature. Another emergency is mucormycosis. We saw a lot during the COVID. This is an absolute emergency because the window is very less. And if not treated aggressively, along with excision and enucleation sometimes, you will lose this patient again. Orbital compartment syndrome. Retrobulbar hemorrhage or sudden bleeding in the eye will cause an increased eye pressure, and optic nerve will get damaged, and the patient will lose sight immediately. So in the emergency, you have to learn how to do lateral cantholysis and canthotomy. Very easy procedure, just a little bit of local anesthesia at the lateral canthus and a 1 centimeter incision, cutting all the structures and cutting the lateral canthal tendon can save this patient's eye. We saw a few patients of dengue hemorrhagic fever with internal bleeding and loss of sight bilaterally very quickly. So a little bit of this can help. Thank you. Thank you.
I would like to thank Dr. Priyanksha ma'am for the wholesome presentation, and I would like to call Arshad Wasi sir, WBCRC, for felicitating Dr. Priyanksha ma'am. I would like to call Arshad Wasi sir to felicitate Dr. Priyanksha ma'am.
And this is the last part of the session. And as because the guest and the speaker is from outside, Professor Sudeepa Das, I request, she is the forensic professor in Odisha, in Berhampur. She is the professor of forensic medicine and toxicology in Berhampur Medical College, Odisha. Please come on the dash. Please come on. I request Dr. Jayanta Das, vascular surgeon from Amri Hospital. Please come on the desk. Please sit now. Sit now. Sir, no, okay. So, please. The topic is on the medico-legal and ethical considerations in the ED. So please, you can make it.
A very good evening to all of It's okay, it's okay. A very good evening to one and all. First of all, I would like to profusely thank Dr. Partho, who is my batchmate from VSS Medical College, Burla. And it gives me immense pleasure to deliver few words on the medical, legal and ethical consideration in emergency department. Basically, we know medicine, if I say it is medicine, and I am a professor and have been working here since the last 25 years. M stands for mercy. E stands for empathy. I dare. I ingenuity. C I care. N, that is nobility. E for ethicality. With this, I start my presentation as one has to save oneself before saving any patient. Legally, as today's theme revolves around re-engineering, the emergency care. So, first of all, we should know what is medical emergency, and coming from a legal department, I would like, everyone knows it, the audience is thin and I would like to wrap up very fast. Medical emergency is defined a situation wherein an individual needs such medical attention immediately on an emergent and urgent mode, the absence of which would place his health in serious jeopardy, or where the potential for such need is perceived by the emergency staff according to section 216 of Gujarat Emergency Medical Services Act 2007. Whereas it is defined, the Clinical Establishments Registration and Regulation Act 2010. Emergency medical condition means a medical condition manifesting itself by acute symptoms of sufficient, major, severity, intensity, like severe pain, of such a nature that the absence of immediate medical attention could reasonably be expected to result in such conditions like placing the health of an individual or with the respect of any pregnant woman, the health of the woman or her unborn child in serious jeopardy, or number 2, serious impairment to bodily functions or serious dysfunction of any organ or any part of the body. So, definition, we need to know what basically the components of a medico-legal case fits or it is defined as. Cases wherever the attending doctor, the physician or surgeon, after taking a detailed history and clinical examination of the patient, thinks that certain investigation by the law enforcing agencies are essential so as to fix the responsibility regarding the case as in accordance with the law of the land. So, we should basically know the duty of the RMPs or the registered medical practitioner in MLCs to save the life of the patient and to give primary treatment. The first aid treatment is the foremost and utmost responsibility, is the primary concern. Registered medical practitioner, that is the emergency medical officer, the assistant emergency medical officer, should decide whether the case has to be registered as a medico-legal case or not. That is how the registered medical practitioner would like the case to be decided as per considering its own merits and own values, because each case is different from the other. We know that a consent of the family members or the kith and kin is not required for registration of a case as a medico legal case. So, it is of paramount and of crucial importance to know what categories of ailments, illnesses or conditions they have to be listed under the medico legal cases. One, that is injuries due to accidents and assaults. Suspected or evident cases of suicides or homicides, or even attempted cases of suicide, homicides. Confirmed or suspected cases of poisoning, burn injuries, cases of injuries with likelihood of death, means impending death, sexual offences, suspected or evident criminal abortion. All the patients brought to the hospital in suspicious, mysterious circumstances, a proper history or a history that is mismatching, like found dead on the road, somebody comes and to the hospital or a nursing home and speaks about what happened, and your findings exactly do not match to whatever he is saying. Unconscious patients where the cause of unconsciousness is not very clear, child abuse, domestic violence, person under police custody or even judicial custody, patients dying suddenly on operation table or after the parenteral administration of a drug or any medication, case of drunkenness, brought death, any natural disaster. So the workflow for medico-legal cases brought to emergency. All the patients, all the cases are given a hospital registration number. They have to be issued a registration number. Casualty, upon admission to the casualty, a registration number has to be first issued. One carbon copy is kept as the hospital record, and the first copy is to be given to the investigating officer from the police station of the respective area. The concerned, the jurisdiction police station needs to be informed at the earliest. What are the guidelines to be followed while making a record of the medico-legal case? Be sure that whatever notes are being written, taken, have to be very legible and clear. All the aspects are complete, replete with history, taking examination, diagnosis, laboratory test, treatment and disposition. All the entries to be signed with the date and time by the person receiving the entry, and his or her name and designation should be written in capital letters. Document disposition, advice and referral for further care to be noted. Note the time of discharge and patient's condition at the time of discharge. That's very relevant. Avoid vague, unsubstantiated statements. Obtain a written consent, that is of paramount importance for one and all. I reiterate, a written consent prior to any examination, mostly for a female examination, detailed examination, being the presence of a lady medical attendant, is of utmost importance to prevent any future unwanted hazards. Release the original records only after the order from the court. Record keeping. All the medico-legal case record registers that should be sent to the medical record department, and a medical record officer, a technician, should be deputed to make responsible for safe custody of the record. The records need not be missed, tampered, or it should be preserved for the safety of the physician. Hospital records or file of the medico-legal case should be kept as confidential in the record section till the court delivers the judgment of law pertaining to the case had been issued. For practical purposes, there is no such time limit. It has, because the case file, if it is, if FIR has been filed, it may reopen at any point of time thereafter. If a medico-legal report has already been issued, then duplicate medico-legal report that should not be issued under any circumstances whatsoever unless it is specifically requested by the police, that too in writing or by the court's honorable court's order. Dying declaration. In case of impending death in any medico-legal case registered, the medical officer should make immediately and urgent necessary arrangements for recording the dying declaration. And the police officer on duty, he needs to be asked to, in writing, to call a magistrate. If there is no time to call a magistrate, the dying declaration should be recorded by the doctor himself, but in the presence of two witnesses. The primary duty of the doctor in dying declaration is to ascertain and document the compos mentis, whether he was conscious and in a state, and to ascertain the mental faculties, whether they are normal, so that he can rationally and responsibly tell all the whatever has preceded that has caused to his state, the present state. And that should be at the beginning of the recording. So, compos mentis needs to be ascertained. However, last week the Supreme Court has had made an amendment that dying declaration should be just as a corroborative document, and because as perceived earlier that when any individual, a person who is going to meet his maker soon, will always tell the truth, but it is not always so. So, it should not be made the absolute document that is admissible in the court of law just as a corroborative finding. So, death in a medico-legal case, wherever there is a death, the police officer needs to be informed by the authorities, the physicians who is in charge. The death certificate should not be issued in medico-legal cases, and body must be sent for autopsy or post-mortem examination after filling the appropriate format. All the cases which are brought dead to the institution, in all the cases the police needs to be informed and the body needs to be sent to the mortuary after filling the appropriate form for autopsy examination. Cause of death certification in cases other than the medico-legal case can only be issued by the emergency medical officer or the assistant emergency medical officer or the treating physician. The time limit of certification of the death should be issued within 7 days of death. Consent. Every human being of adult years and sound mind has a right to determine what shall be done with his own body, and a surgeon who performs an operation without the patient's consent commits an assault for which he is liable in damages. Judge Benjamin Caruso. Consent is defined as voluntary agreement, compliance or permission. According to the Indian Contract Act 1872, it defines consent as under section 13, when two or more persons agree the same thing in the same sense. Section 14, consent is said to be free when it is not caused by coercion, misrepresentation, fraud, mistake or undue influence or by any mentally unsound person. Article 21, the legal and ethical expression of the basic right to have one's autonomy and self-determination. The consent must be free, voluntary, clear, intelligent, informed, direct and personal. Consent is an expression of autonomy and represents the right of a patient to make a decision in a medical matter concerning him or her. Any examination of a patient by the doctor without his consent amounts to assault, that is according to section 351 of Indian Penal Code. Protection has been provided to doctors as per section 88 IPC who have obtained informed consent, which states act not intended to cause death done by consent in good faith or for person's benefit. And it should be taken in the vernacular language of the patient. In situations of a medical emergency, consent to life-saving measures is implied. Informed consent is now accepted as the cornerstone of medical, legal practice and medical practice. Competence to decide. He or she should be of sound mind. He should be able to comprehend the implications of the consent given, should be at least 12 years old. Invalid informed consent by intoxication, unsound mind, and by person below the age of 12 years. Medical paternalism. It is an abuse of medical knowledge so as to distort the doctor-patient relationship in such a way so that the patient is deprived of his autonomy or of his ability to make a rational choice. The doctor does not disclose the nature of the illness and the proposed treatment, depriving the right of the patient to accept or reject the treatment. Blanket open consent. At the time of admission, that covers almost everything a doctor might do to a patient without mentioning anything specific. It's practiced in most hospitals. Proxy consent is incapable of giving expressed consent, and a substituted consent is taken from the NOK. Generally accepted orders: spouse, adult child, parents, siblings, and lawful guardians. Exceptions to obtaining consent: emergency life-threatening situation. So anything done on a humanitarian ground is above law. In an emergency, a comatose patient requiring immediate treatment, the mentally ill person requiring treatment when a legal guardian is not available, an intoxicated patient who temporarily lacks the capacity to consent but requires treatment, consent is implied. Consent by spouse, it's not necessary. No right whatsoever to withhold consent to any operation, including the gynecological operations. That is essential to safeguard the health of the other spouse. But spousal consent is essential where there is a possibility of treatment-induced complication of sterility or impotence that affects the marital rights of either spouse involved. Drunkenness, the person should not be examined and blood, urine, breath should not be collected without his or her written consent. But if the person becomes unconscious and incapable of giving consent, the examination and treatment can be carried out and examined without consent if requested from a police officer not under the rank of a sub-inspector of the police. Professional secrecy, confidentiality. It refers to the doctor's obligation to keep the secrets, all the information regarding the patient that he comes to know in the course of his professional work. Contract is an implied term of contract between a doctor and a patient. The information can be divulged with patient's consent. Triage. Triage is a system used by the medical personnel to ration the limited medical resources like the number of doctors, nurses, beds, medicine, oxygen, etc. when the number of injured exceeds the resources available to save the life of the greatest number of patients possible. So I conclude. The medico-legal and ethical considerations in the emergency department are challenging and complex. Emergency physicians must balance the needs to provide the timely, appropriate care with the need to protect themselves from liability. They must be mindful of the ethical principles of beneficence, non-maleficence, autonomy, justice, and confidentiality. Here are some additional tips for emergency physicians to consider when addressing the medico-legal and ethical issues. Documentation, which includes patient's presentation, treatment provided, any discussions with the patient or their family about the treatment options. Get help from other professionals, including a lawyer, ethics consultant, or a social worker. Be aware of your own biases and limitations. Everyone is apt to make mistakes, so it's very important to be humble and open to rational feedback. Stay up to date on the latest laws and regulations. The medico-legal landscape is constantly changing, so it is important, very crucial to stay informed. Thank you so much for giving such a patient hearing at the end of the day. Thank you, Dr. Parthopal, for giving me such a good platform with the stalwarts from covering all aspects of the super specialities, broad specialities, and whatnot. It's indeed a privilege, and I would look forward for more such deliberations. Thank you.
A very good evening. After whatever Madam said, I don't have anything to say. I just try to sum up it as fast as possible because that's the need of the hour. So from the very good morning, we have learned need of the hour. So my job is to finish it up as fast as possible so that we can all move towards our destination, home, hotel, or wherever we do want. Next, first, we want to say one very important thing, that why we are discussing so much about this emergency care and all. Is it connected? At the end of the road, nothing will succeed if it is not economically favorable. It is for any individual entity, it's for any government entity, or it for any of the corporate or institutions. We need to fit it in an economical manner. So before we are going to the details of discussion of all the points what Madam has said, I will come across with a little bit of different concept of healthcare, how actually it works and how it is placed in the real world. So it's not connected, I think. No. It's not connected. No. It's mine connected. এটা আমারটা লাগানো আছে। তুমি লাগিয়ে দাও তো। দাও, চললেই হলো। আমি 2 মিনিট। আচ্ছা। Anyway, স্লাইড তো চেঞ্জ হচ্ছে না। স্লাইড তো চেঞ্জ করতে হবে। There is some technological glitch. We'll try to overcome the technological glitch. Anyway, slide is not moving. So whatever we want to say, what exactly healthcare we do understand and we do realize and we do see it in our day-to-day practice, it's actually a negative economy for somebody who is at sick. What does it mean? It means whatever is the spending, somebody is spending on what we are saying healthcare, it's not giving him anything else. So somebody will be healthy at a 0 level and he is sick when he is coming below the 0 level. The whole healthcare system is trying to pull him back up to 0 level. not +3, +4 or +10. So whatever is the spending in an individual hand, somebody who is sick, it's always a negative economy, and that's the headache for each and everyone. It's for the government, it's for the individual, or as well as for the institution. So we are here stuck with technological glitch. Legally, government, starting from the international laws, starting from the national laws, and there are various state laws and other statutory activities which actually governs the healthcare. Though we are very proud about the professional autonomy, and at the same time we talk about ethics, ethics should not have any law. Conceptually, ethics do not have any kind of law, but in healthcare, this ethics is controlled by an organization called NMC, National Medical Commission, which is enacted and implemented by a National Commission Act. So in healthcare, every ethics, whatever we termed as ethics, it is also a legal matter. So nothing is without legal, everything has a legal control. Regarding why actually we are so fascinated about discussing the things about how we can bring down the cost of healthcare, because if you see the statistics since 2014, our healthcare budget was around 4.9% of our GDP, and in today's world, in 2023, announced rate is 1.9% of our GDP. So everywhere there is a curtailment of cost, what is actually spent to bring back one person from sick to the normal level. Now, in an emergency department, we have seen how we can coordinate with the various departments, at the same time how we can actually serve the society in a bigger way. In this way, we have, it's not working, sorry? Not working, sir. Anyway, leave it. So, we need to think as a whole. It's not any individual, because governments are working to serve towards the society, and definitely the government hospitals and private hospitals both works in hand. And if you look into the COVID phenomenon, it is an excellent work done by West Bengal government as well as all the private hospitals who joined hand so that we can overcome the COVID phenomenon. Legally, it is described in the Human Rights Commission. There are international laws regarding the healthcare, and there are also judicial pronouncement, specific laws, as well as our constitutional provisions, health as a right. If you go to the website of Health and Family Welfare of central government, there are 17 rights written there. It's nothing new. If you go with all these rights, we have to provide the healthcare with our best of the capabilities. That's the legal mandate for each and every institution. If you are owning a healthcare institution or you are a professionally qualified doctor, you can't avoid any emergency care. That's the first and foremost law and legal implication what we have to know. That's all for the today. I like to thank and congratulate the Mission Hospital Group, chaired by Dr. Satyajit Basu and Dr. Partho. I met him for the first time, and thanks for the opportunity, and thank you very much.
I would like to call upon stage Dr. Shudeepa ma'am, and sir, please stay on stage. I request Dr. Pathupal sir to kindly felicitate our speakers.
So summing up, we end this session here. Thank you, all of you, respected Chairman Sir, WBCRC, Secretary Sir, other dignitaries, Professor Suresh David, Professor Sudeepa Das, Madam. I extend my heartiest gratefulness and I thank you. And I'm sorry to some of the consultants whom I have been given time, but the time could not short because already we are running short of time. It is already more than 6:30. So thank you all. I end the session here.